and it should be there, and we should be good to go. So hello, Facebook. We are back again today. I know we did a podcast earlier today with Dr. Alex DeFarias of UPenn, and we discussed arrhythmias, and we discussed genetics, and now we're pivoting over to our Bighearted Warrior Tour, where tonight we are joined by Rochester Regional in Rochester, New York, and their team. And we're going to start our webinar in just a moment. So just some housekeeping messages. Number one, we will not be taking questions from Facebook. If you're on Facebook and you want to join us in a Zoom room so you can ask questions, Stacy in a few moments will be posting a link onto the Facebook page where you can join us in the Zoom room and ask questions. Stacy's going to be very proud of me for this one. For those of you who are in the Zoom room, and you'll be populating as everybody's getting home from work and sitting down and turning on their computer, I'm going to start a poll right now. Yay, I always forget to do it. As we get the diet going, you can just answer the poll, and sometime around the break after the first presentation from Rochester, I will read the poll out and let everybody know where people are coming from. So for those of you who do not know, my name is Lisa Salberg. I'm the founder and CEO of the Hypertrophic Cardiomyopathy Association, and I am joined here tonight with Stacy Titus, our Center of Excellence Coordinator. Stacy, say good evening to folks.
Hello and good evening, everybody.
And we're going to be managing, I'm going to be managing the questions throughout the night. We'll be moderating. Stacy will take care of any technical issues that anybody is having, whether you're faculty or a participant. You can send her a note through chat if you have any problems. And God forbid my computer crashes, Stacy will be here monitoring things while my computer crashes. That doesn't happen often, but it did happen once. Okay, that being said, I welcome you all to this edition of the Bighearted Warrior Tour. And I am going to hand over the microphone to Dr. Bipul Bipal, who not only is a lovely gentleman and a knowledgeable HCM expert, but has what I consider the most fun name in hypertrophic cardiomyopathy. So Bipul, would you please introduce your team to our participants this evening?
Hi, thank you, Lisa, and thank you for this great opportunity to talk about our program to the HCM community. So I'm Bipul Bipal. I'm the director of the Hypertrophic Cardiomyopathy program here at Rochester Regional. Joining me on the panel today are Dr. Scott Feitel, who is our advanced heart failure expert and director of the heart failure program and the cardiac ICU. Then we have Kimberly Provenzano. She is our par excellence genetic educator and counselor who does a great job with all our hypertrophic cardiomyopathy patients as well as hypertrophic cardiomyopathy spectrum disorders. And we have well-known Dr. Jeremiah Depta, who is a renowned structural interventional cardiologist. So he performs alcohol septal ablation for us, but he also is an expert in advanced valvular heart disease and treating those conditions with minimally invasive approaches. So that's our team. Some of our members are obviously not here on the panel today. So Ludmila Kuchma is our nurse practitioner for the hypertrophic cardiomyopathy program, and she's very dedicated to our patients, spends a lot of time with them, and really performs a lot of the shared decision making along with me and our other team members. Dr. David Chiran is our cardiac surgeon who performs myectomy, and Dr. Dimitri Chuprun, who's our electrophysiologist. We are located in upstate New York. So we established our center in 2019 when Lisa visited us and gave us some great tips to organize our program, and also connected us with some leading experts like Dr. Naidu, Dr. Lever, who's been a great mentor and friend now, Dr. Martinez, so that we could imbibe their expertise and gain experience and ask a lot of questions. So that has really helped us, and I am very thankful to the HCMA for helping us connect with these experts. Prior to the establishment of our center, patients had to travel about 300 miles to Cleveland or Pittsburgh or the New York City area. But now we can provide comprehensive care to hypertrophic cardiomyopathy patients in our region itself. We are a large system with around 9 hospitals in the Finger Lakes region of New York. We also have some hospitals in the Adirondacks in the North Country. So we have a large footprint, and we see patients not only from our 50 or so cardiologists, but a lot of referrals from the Buffalo region, Ithaca region, Syracuse region, and even some as far as Albany or Vermont border. It's been an honor to take care of patients, and thank you for having us this evening.
Fantastic to have you here. I'm going to kick us off, and I've got to already give a little tip to what's going to be showing up on this poll. This is unique for us. I can tell you, we've only had 21 of you even so far do the poll, so keep them coming in. You've got Northeast, Southeast, Midwest, Western United States, Australia, Asia, and other. I'm not sure where other is. Other, I'm going to need you to tell us in the chat where you're from, because other's quite intriguing. Because, like, are you from Antarctica? Where are you people? I would love to know where you're watching us from. So we're global tonight, guys. So I hope you feel good about that, because I do. I think it's pretty cool. All right, I'm going to get started with some acknowledgements and some updates today. So I'm going to start my screen. For our faculty, as anybody's presenting, you're welcome to mute yourself and turn off your camera. And as the speaker before you or the speaker rounds up, you can bring yourself back on camera and make life easier. Am I on the right screen share here? Yeah, okay. For some reason, my little green bars aren't showing up. So good evening, and this is our agenda for the evening. I want to give a big shout out and a thank you to our sponsors. Imbria Pharmaceutical, Tenaya Therapeutics, Bristol Myers Squibb, and Cytokinetics. Without their support for programs like this and others, the work of the HCMA would not have the breadth and reach that it has. So thank you to our sponsors for allowing us to bring this education directly to patients and families. So tonight we're going to be talking about shared decision-making. Imaging is the starting point. So how do you use imaging to aid in shared decision-making? We're going to talk more about genetic testing and how to interpret results. We're going to talk about diastolic dysfunction and non-obstructed HCM. This is a unique subtype of HCM. It's not incredibly common, so I'm really grateful that we're going to have a great talk on that tonight. We're going to talk about HCM and aortic stenosis in the elderly. I have to be honest and tell you, we probably have been way too light on content directed towards the elderly population. The good news is elderly people have hypertrophic cardiomyopathy, and we all aspire to be elderly someday. So we're going to talk a little bit more about that. You're going to get some contact information, and of course, we'll have an opportunity for Q&A at the end of the evening. As we wrap up our Q&A session, we will stop streaming on Facebook, and we will stop recording in the webinar, so that if you have any questions that you wish to ask that do not remain on the internet for all time, even if it's just a written question, it's not you personally, you'll have an opportunity at the very end of the evening to ask a question in the confines of the webinar only. We do ask that as you're asking questions, you make sure that you're not seeking consult by webinar. The doctors are not going to be able to give you specific medical advice for your exact situation, but they can answer general questions. So please be respectful that this is not an individual consult, but an educational webinar to help give you the tools and ability to have an educated conversation with your chosen healthcare provider. Okay, so I've got some fun updates for you. I'm always like talking about like hard stuff, but I want to say thank you to everybody who participated in whatever way you did during Heart Month and HCM Awareness Day. So we ran out of t-shirts, we got some late, so we sent them all out. So if you didn't get your t-shirt for HCM Awareness Day, we're sorry, but you should have it now. It's a good problem to actually have run out. So if you still want them, we've got a few more here. So if there's anybody who's wanting to buy those, they can go to the website. So, oh, and you can watch the sessions now on our YouTube channel, and you'll be able to watch a rebroadcast of this presentation. So if you're feverishly taking notes, don't panic. You're going to be able to review this at a future date on our YouTube channel. There's a lot of content on our YouTube channel, and I would highly encourage you all to stop over, listen to different people's perspectives on different topics. There's a lot of content. You can also see the podcasts there as well. I want to say thank you to states who passed either resolutions or laws for HCM Awareness Day. Ohio passed a law, and then all the resolutions and laws aren't all up here, but New Jersey, Connecticut, Utah, New York, Idaho, Iowa, Indiana, Arizona, Arkansas, Illinois, Massachusetts, Nevada, Kentucky, and South Dakota all passed legislation or resolution recognizing HCM Awareness Day. We've got a couple more states to go, and we've got more legislative action you'll hear about later. But a big shout out and thank you to all of those governing bodies for recognizing the importance of our community's ability to be seen. For those of you who have not seen A Man Called Otto yet, I highly encourage you to do so. It's a tough movie. It's a drama. It's a comedy. It's a little dark, but Otto has hypertrophic cardiomyopathy. And we held 2 viewings of A Man Called Otto, one in New Jersey and one in California. And we had a lot of you come on out and watch with us, and we shared some commentary. It was a lot of fun. We may do some other events throughout the year around Otto, so stay tuned for that. I'm throwing some big numbers out at you people. This is our social media performance during Heart Month, and this just tells you how many people we engaged and through what means. We're not a big Twitter organization, but for us, 22,000 impressions on Twitter was a good number. Our website had a big uptick in traffic. We had 16,000 new users, 50,000 views, 138,000 engagements. So people were going from page to page. 18,000 people came back to visit us, and our time on page grew by about 20 seconds, which doesn't sound like a lot, but it is a lot for web. Our LinkedIn community, we put out 53 posts. We had 15,000 impressions roughly. We had a 6% engagement rate. We had a lot of clicks through to events that were going on and signing up for things. Our Instagram page is popping. We did 60 posts. We had 62,000 impressions. We had a good reach. We had a lot of engagement through comments, likes, and new followers. Facebook was our biggest social media platform. We did 95 posts, 165,000 roughly impressions, almost 5,000 reactions, 7,800 clicks on links, 11,000 engaged users, and 180 new followers. So these are all good numbers. Keep sharing our content from social media. Engage your social media network in as well. This allows us to raise awareness. So we had 95 posts. Oops, a daisy. This is a duplicate. Sorry, there's an error here. We'll fix that. Otto, we had 200 people show up and view the video or the movie with us. Our media tour, I did a TV media tour, radio media tour combination. That was in partnership with Bristol Myers Squibb and Dr. Matthew Martinez from Morristown. And we reached, I think the number was somewhere in the neighborhood of 22 million with the entire reach. I could have that number a little bit wrong, but I think it was like 22 million total. So we got the word out, people, and we're going to do it again next year. So stay tuned for us in about November, looking for more stories, more content to share during Heart Month for 2024, because it's kind of like the Macy's Thanksgiving Day Parade. We're already planning next year. Okay. So one of the major initiatives of the HCMA in coming years is to help find the undiagnosed, and the method in which we are using systematically is a piece of legislation that we're hoping to drop in multiple states. I'm happy to say that the state of New Jersey was the first to implement this type of screening concept, which is adding the pre-participation screening physical questions for heart disease in young athletes to every well child examination, because every child has a heart and every child has a family and a family history. So we want to start discussing family heart health history in the well child examination every year. and giving those families an opportunity to have a discussion with their chosen healthcare provider about what screening might need to be done in that family for whatever particular type of heart disease runs in the family. So it is a sustainable, reproducible, and cost-effective approach to identifying those who have family heart health histories and getting them the cardiac evaluations that they need. If you're interested in joining us in this endeavor, you can sign up as a volunteer on the HCMA's website. Okay, so this is what it does. I'm sorry, I always forget that I have 2 slides on this topic. So it's including the PPE questions in the well child exam. It's increasing physician professional development to do those physicals. Some physicians may have been educated in a time where they didn't know a lot about not only HCM, but ARVC, arrhythmogenic right ventricular cardiomyopathy, long QT syndrome, Brugada syndrome, other channelopathies, syndromes that have HCM or other cardiac components. So we want to make sure that they know what they're looking for. We also want to improve student athlete pre-participation screenings like we've done in the state of New Jersey. We want to enable healthcare providers to make those referrals upstream to cardiology, and that's why we're seeking this particular initiative. I am happy to say that late last year, the state of New York embedded many of the features of the HCM Act in the Dominic Murray Act. So those of you who live in New York State, you have better coverage. We're not quite to where we want to be yet. We're going to try a little bit harder to get some other elements in there, but it's a great start. So bravo, New York. Okay. As the year progresses, you're going to start to hear a little bit more from the HCMA in different formats. We've got a new project called HCM Nest, which we're going to be doing outreach to consent you all to participate in our HCM patient journey registry. It's starting with the 27-year experience of the HCMA and all of those notes that you and I took on the phones together over the years. We're turning that into a formalized database and a registry so that physicians can inquire with us to do research projects. The HCMA can do self-evaluation to identify gaps in care and coverage, and that we can improve those therapies and services to the community by ensuring we understand what's working, what's not working, where there's gaps, and where we need to help people get to care. So as the year goes on, you're going to hear more about the registry. It's getting quite organized, and thanks to the team here at the HCMA and our Medical Affairs Committee for helping guide that development. We're really appreciative. One of the things that we started doing differently in the patient journey registry was asking you all questions in a slightly different way. You may be familiar with New York Heart Association class that tells a doctor how symptomatic you are based on the information you've provided to your healthcare provider about how far you can walk, when you're short of breath, when you're symptomatic, and there's a scale of 1 to 4. The problem with most people with HCM is they don't feel the same every day. So New York Heart Association class isn't a really good guide to determine how well a therapy might be working. So what we did, this is from January, I can update this later with some more data, but in January of 2023, we started asking this question in a different way. Tell us how you feel on an average day. Tell us how you feel on a good day. Tell us how you feel on a bad day. And we found that, not surprisingly to the HCM community, these numbers bounced around a great deal for the majority of people. The circles in red indicate people who are stable in a class, 2 2s, 2 1s, and 1 3. So 5 people are consistent and 32 are not. So why is this a problem? If we're using New York Heart Association class as an endpoint, a goal for a clinical trial, we could be getting some bad information in that clinical trial, which might actually diminish the value of that drug to the population or therapeutic option. What am I talking about? Things like if you go into a doctor's office for a clinical trial appointment and you're having a really bad day, but you typically have 15 bad days a year, and you happen to go to the doctor on one of those 15 bad days, but you report you're having a bad day, that could skew the data to think that the therapy is not working. But in actuality, maybe you only had 2 bad days this year, not 15. So how do you balance that out? Well, that's one of the questions we're trying to figure out, working with our researchers, with industry professionals, with clinicians, and with patients. How do we come up with a better clinical trial endpoint for HCM? And listening to the true HCM experience might help shed some light on where we need to go with this. So the patient registry is important, and your involvement is going to be critically important as we move this initiative forward. The other area where we need to help identify the undiagnosed is a call to action. I'm sorry, this slide was not updated for March, but February is Black History Month, and I love this picture. But we know that in HCM programs, 90% of the patients seen in an HCMA recognized center of excellence define their ethnicity or race as white or Caucasian. That does not represent what's actually happening in society, which is actually visualized here in this really interesting graphic. 61% of the US, this is 2019, so this data is a little bit older, and we're trending on this map over here, which I'll walk through in a moment. 61% are white, 18% are Hispanic, 12.2% are Black, 5.6% are Asian, and then you have the multiple races, Native Americans, and Native Alaskan or Native Indian. So this is not a 90% Caucasian country. So our patient population shouldn't look like that. It should look like this schematic here. And as you can see over time, the white population is going to drop down a little bit, and the other ethnicities are growing a little bit. So we have to make sure that we're providing care models that identify all people with HCM, because we all have an equal chance of having HCM, and we should all have an equal chance of getting in front of an HCM specialist and getting our care managed appropriately. So we're working on a new project. You're going to be hearing more about it hopefully in the next 2 to 3 months. It is called the All Hearts Collaborative. It is inspired by Derek Armstead, a young HCM warrior who lost his battle because he's never given the opportunity of diagnosis, even though there was a significant family history. So we don't want to perpetuate the past and the bad habits. We want to create new methods so that we can identify all with HCM and get them the care that they need. We have many new approaches here at the HCMA that you're going to be hearing about. We're partnering with individuals to evaluate the use of artificial intelligence to help the diagnostic process. We have more partnerships and community allies. We have a new media company that's going to get HCM stories out there in a more meaningful way. So this is all critically important, but if you and your family are having a financial problem and you cannot get to a center, all the good work that we're doing doesn't really get us to the end point, does it? So we built the Lori Fund last year. We started it, and we've already given a couple of grants away. This is for travel money for you to get to a center. If you have a financial need and you need to get to a center of excellence, we'll put $600 up for grabs if you need it. You can get train, plane, automobile, hotel rooms, food on the road, whatever you need to get to that center. Please apply for the Lori Fund. We process them pretty quickly. Once you send it in, it takes us 2 weeks. The application is available online. Just go to the HCNA website and type in Lori Fund, and you'll get the funding, and you'll see the application and the requirements. Drill Dr. Heart is another program that we're working on, and you have until April 23rd to submit in your social media feed to the HCM or to the Drill Dr. Heart Challenge, which prepares your community, however you define your community, for a cardiac emergency. So we know knowing CPR and AED deployment is critically important, but in a moment of crisis, people freeze. They don't exactly know what to do. So how do you get people to be comfortable? You practice, practice, practice. So we want you to practice Drill Dr. Heart. What happens if somebody goes down in your workplace? Are there protocols set up? Who's in charge? Who needs to be trained? Are there Good Samaritan laws that cover you in your state or jurisdiction? Do you have an AED on campus, or is it coming through with the EMS workers? Answering all these questions in advance gives you an opportunity to stop, think, plan, know what you're going to do, and know all of the roles of all the people in the room. If you have 5 people who are CPR certified, great. If 2 of them also have training on how to use an AED, fantastic. But if you find out that nobody at your church is CPR certified, you may want to bring in a CPR training class. They'll teach you how to use an AED as well. If you don't have an AED at your school, your sport, your work, your house of worship, your community center? Do you need to buy one? How do you get one? We can help you with all of that. There's a playbook, there's a challenge, and challenge part here comes into doing the work of Drill Dr. Hart, practice it, communicate it, but then film it and load it onto our platform and enter to win a free AED. We will be giving away 4 AEDs on April 23rd, one for each class that are submitted. So please take us up on a free AED. Go do it, people. You can do this. So that you can find online. Tales from the Heart, a podcast from the HCMA, runs typically every Friday. We did one earlier today. Tomorrow, I will be talking to one of our colleagues over at NYU about a recent publication on diet, exercise, and weight in HCM. Hot topic, interesting advances being made here. So come join us tomorrow morning at 11 o'clock. And this is a big shout out and thank you to my entire team. This does not happen in a silo. I know you hear Lisa's name a lot, but it's not just me. Trust me. If it weren't for our team, we wouldn't be able to perform these tasks that we do as well as we do. So thanks to our whole team. And I want to give a shout out to our 2 new interns, Olu and Ariana, who joined us last week. We're looking forward to working with them over the next couple of months on our legislative initiatives. And April 1st, we welcome 3 new members of our board of directors. So Kevin O'Connor, Rosemary Conlin, and Bill Rossi will be joining the board of the HCMA. I am humbled and grateful for their service. They are a power-packed bunch of individuals who are going to bring some new energy and vision to the board. So I'm looking forward to working with all of them. You'll get to meet them in the next newsletter, I hope, if not April's, then May's. But they're amazing individuals, all from the community and all pretty formidable in their own rights. So I wanted to give a big thank you for this evening's event to our Center of Excellence partner at Rochester Regional, to the staff of the HCMA, there should be a space there, to our board volunteers, and of course to Brandy, my donor. Without Brandy on board here, I wouldn't be here today. So if you have not discussed your wishes for yourself and your family members regarding organ donation, I ask you to take a moment to do so to ensure that others have an opportunity to stay and share their lives with you, because it's been a lot of fun being able to be here for the past 6 years. So thank you very much. And I'm going to hand it over to Bipul, and we're going to start their project here.
Hi, everyone. So today I'm going to talk about shared decision making and role of imaging in shared decision making related to hypertrophic cardiomyopathy. We are located here in upstate New York. So we are the only center of excellence in Western New York. And I'll be going over some of our contact information on how to get an appointment at our HCM center towards the end of this webinar. We provide comprehensive services, including echocardiography, cardiac MRI, CT, genetics. Kimberly Provenzano, who is part of our genetics team, will be speaking today. Cardiac surgery, interventional cardiology, Dr. Depta is on. Advanced heart failure, Dr. Feitel is on. But we provide EP services, preventive cardiology, maternal fetal medicine, reproductive endocrinology. And then we partner with the pediatric hospital in Buffalo, the Oshai Children's Hospital, for pediatric needs of our patients and family members. So we'll talk today about role of imaging and shared decision-making in patients with hypertrophic cardiomyopathy. So one thing I did want to talk initially was, what do we mean by shared decision-making? And this is from an old paper in 2012, which describes shared decision-making as clinicians and patients sharing the best available evidence when faced with the task of making decisions, and where patients are supported to consider options to achieve informed preferences. And this is extremely important, not only for hypertrophic cardiomyopathy, but in all aspects of medical care. But it becomes extremely important in hypertrophic cardiomyopathy because the complexity of each patient or the pathophysiology of each patient is very unique. Why they may be having symptoms is also quite unique. Some patients may have LVOT obstruction, some may have diastolic dysfunction, some may have other comorbidities like aortic stenosis or coronary artery disease. So there are a lot of nuances to why a patient may be feeling how they're feeling if they have hypertrophic cardiomyopathy. And when we discuss genetic testing or whether to implant an ICD or discuss invasive treatment for left ventricular outflow tract obstruction, we perform this shared decision making. And when we talk about shared decision making, I think there are three important factors that are important to make good informed decisions. One is that the recommendations that we make as healthcare providers are evidence-based and unbiased. Second is that we communicate in a way that is clear and tailored to each patient based on who they are and what their symptoms are. And then we discuss goals and preferences in an open manner. We discuss the risks and benefits of each procedure and also discuss treatment burden for the patient. And this becomes especially important in where patients may have barriers to healthcare, which we call social determinants of health. So I think if we perform good shared decision-making where we are sharing available evidence in an unbiased manner and clearly discussing with the patient and tailoring it to their needs, the outcomes are better. And we also address health disparities which might be there. So this is how I think of role of imaging is in shared decision-making in patients with hypertrophic cardiomyopathy. Each patient has a very unique pathophysiology. They may be obstructive, they may be non-obstructive. If they're obstructive, they may be LVOT obstruction, it could be mid-cavitary obstruction, it could be diastolic dysfunction, it can be concomitant aortic stenosis or coronary disease. Multimodality cardiac imaging, if done well, and this includes echocardiography, stress testing, cardiac MRIs, occasionally cardiac CT, sometimes transesophageal echocardiography, good quality exercise testing, good Valsalva maneuvers with echocardiography, really help us identify this unique pathophysiology. And once we identify the unique pathophysiology, and once we can understand the reason why the patient may be symptomatic, then we are able to clearly communicate that with the patient and make evidence-based recommendations. And this leads to better understanding on the patient's part of what are the options, what are the pros and cons of each approach, and they can make informed decisions. So with this in mind, I have 3 or 4 cases which I would like to go over and show you examples of how imaging helps in informed decision-making. So our first patient is an 80-year-old gentleman with history of recurrent postural syncope for many years. So a lot of episodes of fainting for many years. He has other comorbidities as well. He is frail, he's 80-year-old. And monitors dating back to 2016 have shown what we call non-sustained ventricular tachycardia. So this is normal electrical activity of the lower chamber. And here you can see there are 6 or 7 beats in succession, okay? So when we see him in the office, the question is from a referring provider, should we implant an ICD? And could this be arrhythmic syncope related to ventricular tachycardia, although all past monitors have just shown short runs of arrhythmia from the lower chamber, not enough to explain his passing out. And his passing out episodes based on history seemed like maybe related to the blood pressure dropping, which we call orthostatic hypotension when he stands up, which many people who are elderly can have, or it could be related to outflow tract obstruction in patients with hypertrophic cardiomyopathy. So this is his echocardiogram. And what we can see is this is the left ventricle, this is the aorta, this is the mitral valve, and there is some basal septal hypertrophy or thickening of the basal septal wall. We see a little bit of turbulence, and even with Valsalva, we do not see any significant obstruction. Actually, there is no obstruction. So he has an MRI, and what we can see again is this basal septal hypertrophy. The anterior mitral leaflet is not elongated. This is the aorta. There is no evidence of any turbulence to suggest obstruction in the LVOT in this patient. And these are his MRI images looking for scar. This is in this view, but there was no evidence of any scarring or fibrosis of the heart muscle. So when I met this patient, I reviewed the MRI, and his symptoms seemed related to either orthostasis, where the blood pressure was dropping when he stood up, or related to now that I see that he has some obstruction, we bring him back for an echocardiogram. And this is his echocardiogram. Again, he did not have any obstruction at rest or with Valsalva maneuver while lying down, but when we stand him up, we see some increased turbulence in this left ventricular outflow tract. Again, this is the left ventricle, this is the left atrium, this is the aorta, and we can see this basal hypertrophy and some turbulence. And when we do a standing gradient, we see that there is severe obstruction here with a peak gradient of 49 millimeters of mercury. And then when we ask him to do a Valsalva, which makes him a little lightheaded, interesting because that can worsen the obstruction, we can see that this peak gradient is 66 millimeter of mercury. So now, with the help of imaging, we know why he's having a history of postural syncope on standing up and why he's been having it for many years now. We discussed with this, he was apparently frustrated because he kept having these episodes for a long time, but with good quality, thoughtful imaging, we were able to answer the clinical question. I reviewed the images with him, and all it took was some beta blocker and maintaining hydration, and he's not had any passing out episodes in a year. So we tailored therapy based on his needs. He's an 80-year-old gentleman. He has other limitations. All he wanted to do was not get lightheaded and not have fainting when he stood up. With a little bit of medical therapy, we were able to alleviate his symptom. This second patient is a 30-year-old gentleman with hypertrophic cardiomyopathy who's been having shortness of breath on going up 2 flights of stairs or on walking up an incline for the past many years. And he even remembers that he had difficulty keeping up with his peers since his teenage years. And we initially saw him because he presented to the hospital with atrial fibrillation. And you can see an irregular rhythm on his EKG, which is consistent with atrial fibrillation. And obviously, the question we ask in someone who presents at 30 years of age with atrial fibrillation, that is very unusual. So is there any structural heart disease? And these are his MRI images. So what you can see is, and this is one video of his heart, but it tells us a lot of information. What we can see is the gray is the heart muscle here, and the white is the blood. What we can see is that his septum is extremely thick, quite thick. He has this reverse septal curve morphology of hypertrophic cardiomyopathy. And what we can see is there is significant dynamic LVOT obstruction. I don't have that image in the interest of time, but his gradient was more than 100 millimeters of mercury. We can also see that the anterior mitral leaflet is elongated and redundant. And when the heart squeezes, this anterior mitral leaflet comes in very close proximity to this basal septal wall, resulting in this turbulence in the LVOT, so high degree of dynamic obstruction, and also this posteriorly directed jet of mitral regurgitation related to systolic anterior motion of the mitral valve. So, and the other thing that we see is that the 30-year-old should have a normal size of this top chamber of what we call the left atrium, but his left atrium is already enlarged. We also see the papillary muscles may be a little more apically displaced than usual. So obviously, he was at very high risk of thromboembolism because in patients with hypertrophic cardiomyopathy, we do not look at the traditional risk factors for atrial fibrillation, but if they have hypertrophic cardiomyopathy and if they have episode of atrial fibrillation, they need to be an anticoagulation to decrease the risk of stroke, which can be a major cause of illness or even death in patients with hypertrophic cardiomyopathy. When we, so based on this image, he was very agreeable to taking the anticoagulation because he understood the risk because he could see it himself. And we were able to explain him better. He had some scar in the heart muscle, which are these white spots that you see, the patchy areas of fibrosis or LGE, what we call as late gadolinium enhancement on contrast MRI in areas of hypertrophy consistent with hypertrophic cardiomyopathy, and his wall thickness was around 2.2 centimeter. So everything consistent with history of dynamic LVOT obstruction and hypertrophic cardiomyopathy. So now it was time to discuss options. Obviously, we saw him in the hospital, so we got him into a normal rhythm. We started him on a blood thinner medication, but then we discussed that he's a young individual. He's only 30 years of age. His left atrium is enlarged, and his likely trigger for the atrial fibrillation is this dynamic LVOT obstruction. And we tried medical therapy, and he continued to have significant obstruction and significant symptoms. And this was prior to approval of mavacamten for hypertrophic obstructive cardiomyopathy. So we discussed with him, and he chose extended septal myectomy for alleviation of this LVOT gradient, but also that would decrease his risk of atrial fibrillation. So he underwent extended septal myectomy and also a maze procedure where the surgeon puts lines on the left atrium in order to reduce the risk of future AFib. This is intra-op TEE. What you can see is that the septum, part of the septum has been resected, and then the LVOT looks much clearer. This is his stress test 3 months later, and even with peak exercise at a heart rate of 110 beats per minute, there is no evidence of any dynamic obstructions. He has been doing well and has been recurrence-free with no episodes of AFib, and it's been a couple of years since his surgery. So again, demonstrating how understanding the mechanism of why he was short of breath and what may be triggering his atrial fibrillation helped him understand the need to take blood thinner medication for history of atrial fibrillation, and also helped him make informed decision about septal reduction therapy with extended septal myectomy. This is a 35-year-old lady who had symptoms of shortness of breath and fatigue for many years. So again, very young individual, many years symptoms. And what we can see is this is the echocardiographic image. And this is a patient we saw last year, and you can see the sigmoid septal morphology of hypertrophic cardiomyopathy, where there is this septal bulge. The other segments of the septum look okay. There is systolic anterior motion of the mitral valve. So what you can see is there is turbulence in this left ventricular outflow tract. And then related to systolic anterior motion, there is some mild mitral regurgitation. So her symptoms were related to LVOT obstruction and maybe more mitral regurgitation with exercise. And then when we do a Valsalva maneuver, she has this classic dagger-shaped jet of dynamic LVOT obstruction with a peak gradient that is extremely high of 132 millimeters of mercury. She was already on beta blocker therapy. We had also tried diltiazem, and even with combination therapy, she continued to have significant symptoms. Her septal thickness was around 1.7 centimeter. So after this, we met her after the approval of mavacamten. So after discussing goals, benefits, discussing the REMS program, making sure she could come to all the appointments and follow up closely and checking for drug interactions. This is her echocardiogram on with 4 months of mavacamten therapy. We utilize contrast so that we can accurately determine the ejection fraction and make sure there's no decline in ejection fraction. So this is actually echo contrast, which is different than MRI contrast or CT contrast. This does not affect the kidneys at all. And what you can see is that the heart ejection fraction remains completely normal. LVEF estimated was around 65–70% on 4 weeks of mavacamten therapy, and we see a significant decrease in the degree of dynamic LVOT obstruction just at 4 weeks. So again, imaging here really helped her understand what was going on, what was the reason for her symptoms, especially since she had been experiencing symptoms for a very long time, and then also helped her understand and make informed decision about therapy. So as in hypertrophic obstructive cardiomyopathy, obviously there is new medication mavacamten, we have alcohol septal ablation, we have septal myectomy, but keeping patient factors in mind, we can go over risks and benefits of each approach, look at what patients' preferences are, so that they can make the best decision. This is another gentleman who is 55 years old, and he presented with only a couple of weeks of lightheadedness. So his symptoms were not prolonged. And if we look at the EKG here, this blip here is the electrical activity of the upper chamber. And this bigger blip is the electrical activity of the lower chamber. And this is called the P wave, the upper chamber. This is the QRS of the electrical activity of the lower chamber. And what we see is there are 2 Ps for every QRS. So this is what we call heart block. So patient had a conduction system problem, which is called heart block. So that is why they were lightheaded. So obviously patient presented acutely to the hospital because they had symptoms. When somebody young in their 50s presents with heart block and they do not have history of really uncontrolled hypertension or diabetes, then we think why they may be having a heart block at age of 50. And when we do the echocardiogram, we see a surprise finding of what looks like apical variant hypertrophic cardiomyopathy. So what we can see is that the apex is thickened. There's some thickening of the septal wall too, but it's like spade-shaped heart. So this is the left ventricle, and there is apical hypertrophy. And when we do a cardiac MRI, what we see is that there is some enhancement here, which is fibrosis in this wall here, in the septal wall, which we call the mid-inferoseptal wall, and then also a little bit in the inferior wall and some fibrosis or LG in the apical segments too. So he presented in the hospital acutely, so we had to put a pacemaker in him. But after we discussed with the patient, we showed him the images, and we said that this, although it looks like apical variant hypertrophic cardiomyopathy, but patients with hypertrophic cardiomyopathy do not have heart block usually. They have atrial fibrillation, they have ventricular arrhythmias, but heart block is not really that common. Based on this discussion, a patient who was initially hesitant to pursue genetic testing was agreeable, and he saw Ms. Provenzano, who will be giving a talk after me. And actually, his genetic testing showed this pathogenic GLA mutation, which is consistent with Fabry disease, although an atypical variant of Fabry disease, which is associated with usually just cardiac manifestations. These patients usually do not have neurological or renal manifestation, and his therapy, his mutation was amenable to treatment with an oral agent. He also, since he had the pacemaker, we were watching him, and he had frequent non-sustained ventricular tachycardia. So we reviewed that with him, and then we upgraded his pacemaker to an ICD. So in summary, this is my last slide. I think quality imaging is extremely important. We have to aim for high quality imaging. And in patients with hypertrophic cardiomyopathy, especially that obstruction, which may be latent or vary from day to day, it's very important to make sure there is no obstruction by using different maneuvers such as Valsalva, standing, either doing an echocardiogram with exercise or after fasting, or when they've just had a meal. So it's extremely important that we use good quality imaging, use echo, use MRI, use genetics to really achieve that accurate diagnosis. And once we have the accurate diagnosis, then this leads to better understanding from the patient's perspective and also the physician's perspective, and then we can make informed treatment decisions. And HCM centers of excellence like have really have the imaging technology, and over a period of few years, we've really developed the expertise to make that accurate diagnosis. I think that's it from that was my presentation.
I like the image. You have a beating heart.
Yes.
Thank you for that very thoughtful and detailed presentation. Before we get to answer some questions and ask you a few, I do want to go back over our internal poll so you know who you're talking to. And might I say, tonight we have a rather eclectic group with us. So if you have not taken the poll, I'm going to give you like 10 seconds to go do it before I hit the button so I can publish it. So we've got a little bit more than half of the people responding right now. And 1, 2, 3, and you guys are done. So I'm going to share the results with everybody. We have representation from the Northeast, the Southeast, the Southwest, the Midwest, and the West of the United States. We have no Canadians with us. I don't know what happened to the Canadians or the Europeans, but we have Australians, Asians, and other. I'm intrigued by the other. If you answered other, please tell me in the chat box where you're from. What is your relationship to HCM? So 38% are patients, 5% are patient and also have a family member diagnosed. 14% are a family member. We have a large medical community here today. We have 24% are healthcare providers and 19% are industry representatives. Have you or a family member had any of the following? Answer all that applies. So we have 30% that are the newly diagnosed, meaning in their first 2 years. 51% are on meds, 22% have ICDs, 8% have had a septal reduction therapy, 16% are in atrial fibrillation, 22% of us have lost members to HCM, family members to HCM. I'm the only transplant, I guess, heart transplant related here tonight. 46% have had genetic testing. That's a good number out of this, but we could do better. 8% have been advised to get an ICD, and 5% have been advised to consider septal reduction therapy. So tonight we have 19% of those participating that are evaluating their treatment options and hopefully using what they're gaining here tonight as part of their shared decision making. So that's, you've got a well diverse group. There was a couple of questions after my talk that I didn't quite see. Who I will be speaking from at NYU is Maria Reuter, who was the author of the article that was published last week, Weight Loss and Hypertrophic Cardiomyopathy, a clinical case series. So we'll be discussing that tomorrow morning. And Gautam, you asked, are services free? I don't know which services you're talking about. Could you please expand upon your question? And I will be more than happy to answer it for you. So having said that, imaging in HCM, you embarked on an interesting adventure when we met, and I introduced you to somebody named Harry Lever. Did you, prior to meeting with Harry through all these sessions, see what you see now? in looking at images?
I have learned a lot from Dr. Lever. So I think we've had probably close to 100 sessions over the past 3 years or so. So one thing that I learned from him is hypertrophic cardiomyopathy is not of the obstructive type, is not just the septum, but a lot of it is the mitral valve. So that is a very important concept because, and now with especially MRI, we are able to look at a lot of these abnormalities of the mitral valve and the mitral valve, what we call apparatus. So many patients may not even have much thickness. We've had patients who the wall thickness may be 1.3 centimeter or 1.2 centimeter, but have a really elongated mitral valve leaflet. Or they have anteriorly or apically displaced papillary muscle or a bifid papillary muscle. So these are all important things that can lead to obstruction. So one thing that I learned from Dr. Harry Lever is not just the LV wall thickness, it's more than that. The other thing I also learned about is that when you see turbulence in the LVOT, and even though the gradient is normal or slightly elevated and the patient's symptomatic, you have to try to do more. So some of these patients, obviously initially, when our patient volume was less, I could be there for every echo and stress echo, but then we trained our sonographers, and we have a team of sonographers that does it very well. But still, if there is an HCM patient who's getting an echo and a stress echo, I expect a phone call to review the images, because sometimes the obstruction may be very latent, and standing with Valsalva, we had a patient today, standing with Valsalva really brought out the gradient. So I think those are some of the things that I've learned from Dr. Lever, apart from many other lessons.
I think the way both he and Mark Sherrod and Barry Marin do imaging, they've elevated it in HCM to an art form, and I'm hoping that we create a more structured program so we can teach more people the tips that they've developed over 40 plus years of their career. And I was really happy that I made that connection, and you guys lived happily ever after and became friends. So we love Harry. So there might have been a problem with the chat earlier. My apologies. The chat feature may have been disabled. It should be working now. And we have a question from Hugo. How often should an HCM patient have an MRI? What is the frequency? And can you discuss the safety of MRIs with ICDs?
Great questions. So a patient who is diagnosed with hypertrophic cardiomyopathy, we like to get an echocardiogram every 3 to 5 years, because what we want to see is there any change with regards to increase in thickness? We want to also sometimes want to get an accurate estimation of left ventricular ejection fraction, if their left ventricular ejection fraction is borderline, and also look for any increase in degree of fibrosis or new fibrosis that might have developed. So usually the interval in adults is about 3 to 5 years. Obviously, depends a lot on patient factors, how old they are. So the hypertrophy, the changes in wall thickness happen more at younger ages. It has been reported that that can happen in the elderly too, but in younger ages, if somebody's 20, then definitely I want to get an MRI in 3 to 4 years. Rather than, or if somebody is 70, then obviously they've kind of declared themselves low risk. So we take into account all those factors. With regards to implantable devices and MRI, the Heart Rhythm Society came up with guidelines about the safety of and the protocol for even non-conditional, which means these are some of the legacy devices. So nowadays, over the past 5-6 years, we implant devices which are MRI safe, and that can be done with a institutional protocol, which we have and most institutions have. But even if the device is non-conditional, there is enough data that we can do the MRI safely with institutional protocols and based on mechanisms to prevent any adverse events. And we've done many of those.
So back in the early days, we were very afraid to put the generators in MRIs. We were very afraid of the leads and how they may conduct energy and thereby make the leads not as safe. I can remember hearing back 15 years ago that the FDA is like, we're pretty sure they're safe. We're pretty sure they're safe, but they took a lot of time to get to, yeah, we look good here. So just because you have an ICD doesn't mean you cannot have an MRI. However, can you talk about the drop off and the shadowing that can occur from the generator?
So if the generator is, we look at few things we look at when a patient with MRI, with HCM and has a device. So first we look at how old is the device, because some of the older devices had a bigger profile and that can cause more shadowing. We also look at where the device was implanted, because if it's a little bit higher up in the chest and it's away from the heart, it usually works out. Even if it is kind of close to the heart, usually we'll ask the patient to lift their arm up during the study. And we try to minimize the amount of time that they are in so that the device moves a little more superior and away from the heart. Cardiac MRI is usually done with end expiratory breath holds, but in patients with hypertrophic cardiomyopathy, and if they have a device, we'll do end inspiration so that the diaphragm is lower. And so I think in most patients, we get imaging to accurately assess the wall thickness and look for fibrosis, and we are able to achieve it in most patients. With, there are some nuances which we have to look into, but most patients, we are able to achieve it.
Anybody else on the team have any comments on MRIs and HCM? I can talk. Been talking all damn day. No other comments. Okay, Gautam, I'm going to reply to your question in writing, and I will help address that. He's actually viewing from India, and he's asking about access to care questions. So Hugo, thanks for the thoughtful question. We've answered that live. If there's additional questions, please ask them. But we're going to pivot on to our next speaker, and we're going to bring in Kimberly, and we're going to talk about genetics and HCM. And she turned off her camera. Now come back. Okay.
I'm back.
You're back. Okay. So as a reminder, the chat feature is for administrative tasks. The Q&A box is where you would post your question. The reason we do that is we can keep all of those questions for future programs. So if you would please, JG, who just posted in chat, would you please repost your question into the Q&A and we'll answer it at the next break. Thank you very much. Kimberly, you want to do screen share and we'll get you started.
All right. Whoops. Did I say I would do this? Screen
Most
share.
common words in a webinar is you're on mute and whoops.
All right, I lost screen share. So let's see.
We'll find it.
Nope.
At the bottom of your screen in the green box.
Did I call this? No. Don't see it. Don't see it. Didn't we say F5 would do it?
I've never heard the F5 trick.
Did you share your screen? If you could share your screen first. We don't see your screen. So it's the center button in the bottom. Share.
Testing my technology here, guys. Not a great start. I promise my talk will be better.
I know that it will, but we just have to hit those buttons. So at the bottom of the Zoom screen, you'll have the green share screen button, which should be about center of the webinar. And that's part one. And then you choose which screen if you have two screens. And that might be where you're thinking the F5.
Green button.
Green button at the bottom of the Zoom screen. Share screen with little up arrow.
Did I lose you guys?
We're here, but we're behind another screen would be my guess. You probably got too many things open. Yay.
How are we
we're almost
doing?
there. Yay.
I don't. Okay. Do you hear me though? I don't hear you.
We're
Yes, we
here.
can.
I hear
You hear
you.
me?
Yep,
You're
you're
All right.
good.
Well, as long as you can hear me, I guess we're good to go.
Yep,
I don't hear you, but we're good.
we're good.
So thanks, Lisa. Good evening. Now that we got that cleared up, I appreciate the opportunity to be with you tonight to discuss genetic testing and HCM. I am extremely grateful to Lisa and her amazing team for bringing us together to highlight the amazing work of my colleagues, which you will hear from. So HCM and genetics, what we know, what was once considered rare is now the most common genetic heart condition, with worldwide distribution and estimates of 1 in 200 to 1 in 500, depending on who you talk to and which data you look at. We know that HCM often goes diagnosed, undiagnosed, and sometimes misdiagnosed. But since its initial application in the early 2000s, we are now increasingly utilizing genetic testing to provide more comprehensive care for HCM and other cardiovascular conditions. Now, can I do the next slide? No, guys, this is so fun. I don't know if it's, I'm trying.
Okay, so I'm gonna try to do something here real quick. View options. I'm gonna request a remote
I could
control.
advance it
Kimberly.
before. Wow, you're good. Can you
Okay,
advance it?
so-
For some reason, it's not advancing for me. There we go. I said you were the best. I was right.
All you know, girl, all
So
you.
let's talk about the clinical utility of genetic testing. I think right now, current time, the clinical utility is really to support the diagnosis of HCM, to help us differentiate HCM from phenocopy conditions like Fabry, amyloid, and Danon, which Dr. Bippel illustrated, Dr. B illustrated in the case earlier. We know that there are conditions that mimic HCM, both symptomatically and in their clinical presentations, but they originate from very different mechanisms of disease, and they have different treatment pathways. So what I'm seeing in the clinical genetics realm is that we are making sure that we are supporting and confirming the clinical diagnosis, and sometimes we're surprised. Sometimes we find things that take us down a different pathway for patients. So that's certainly very important. I also think it helps patients provide reassurance that they're on the right path, and that's important also for their families. So what we know about HCM is that it's inherited autosomal dominantly, meaning that it only takes one abnormal mutation or mistake in a gene to actually have risk for the disease. We can inherit HCM from either side of the family, dad or mom. There are some conditions that overlap that are possibly X-linked, but HCM is a monogenetic condition. It is not linked to female or male sex. There's a 50% chance of inheriting it and also passing it down to offspring. Some of the other useful implications and manifestations of genetic testing as far as informing family members we've known about for a long time. So, but I think we've really moved past using genetic testing just for family member management, although that's extraordinarily important. We are now seeing it used to inform the management of the patient. We are a ways away from risk stratification, but I think that's coming. So in other words, looking at particular mutations and finding out how those mutations increase exact risk and whether or not we should be stepping up some of the treatment cascades. Genetic testing is also helpful in reproductive planning for people who are considering having children. Somewhat, controversial depending on your perspective, but also this opportunity to provide pre-implantation genetic diagnosis also can provide reassurance and hope to people who have particularly devastating family histories of disease with respect to being able to have a child that is not affected by a genetic mutation. Next slide. Thank you, Lisa. So this one's a bit overwhelming, but HCM genes, the list goes on. So our data with this is pretty complex. We know the two heavy hitters are MYBPC3 and our MYH7. If you look at the pie chart, those still make up the bulk of genetic abnormalities that run in families. The big point is that we still have a long way to go with this because we identify no mutations still in about 40 to 60% of patients. And by no mutation, that does not mean that this is not an inherited condition. It's just that we can't find it based on the genetics. So there's a lot of research looking at polygenetic risk scores and other causation, but so far we are still a ways away of having all the answers with genetics. And then the slide to the right shows how complex the genetic information can be with respect to how the patient presents. So there's a wide variety of clinical overlap. As you can see, HCM genes listed in the big blue circle, many of them can cause other conditions, rhythm disorders, etc. So the important thing about the genetic testing that we're able to do now is that we don't just check two genes, we can check a large panel of genes that have clinical overlap with some of our other cardiovascular conditions. Next slide, please. Okay. So what about the test results? When we do genetic testing, there's a variety of test results. For the most part, they are either positive, which means that a disease-associated mutation is identified, and that doesn't mean that it's just specific to HCM. Like I mentioned, it can be some of these other phenocopy conditions. When we identify a positive genetic causation, we know that the patient is at risk for developing disease. That does not mean that they will develop disease. That also does not tell us when or how severe their disease will be. So there is quite a variety in expression based on the genotype. So we have to counsel patients about that, and we often tailor the genetic findings to the family history presentation. We mentioned that genetic testing can be used for predictive cascade testing. So this is where the test results are extraordinarily helpful for family members. If we identify the causative mutation, we can then use that to inform risk to family members. Informing risk to family members is valuable. We have a lot of data that suggests that people that learn of genetic risk are actually more motivated to undergo screening that they might not otherwise think is crucial. So that can be very helpful. It can also tell us who in the family is not at risk for developing the disease and who can avoid some of the worry and some of the excessive screening. The other test result that we see is a negative result. And I find a negative result is probably the most difficult result to give because number one, it doesn't answer any of the questions that we're desperate to find. It tells us that we did not find a disease-causing mutation in the gene line. It does not mean that the disease is not present. So sometimes patients misunderstand a normal result. Maybe I don't have HCM. Maybe I don't need to, worry about this, or my family doesn't need to worry about this. And that's not true. We know that that HCM runs in families, and just because we don't find a genetic cause doesn't mean that. So when we get a negative result back, we are sure to reinforce the importance of family member clinical screening. So a negative result means we didn't find a cause. Genetic testing generally won't help other family members for clarifying increased risk. So we must assume that all first-degree relatives are at risk and do still need clinical screening. So we're sure to reinforce that concept. Uncertain significant results is a hot topic. People don't like them. The larger the panel of genes that you order, the more noise or the more VUS you will get. This result means that we don't have enough evidence or data to understand that this is the cause of disease in the family. And sometimes that's pretty tough to explain because we want to know, and we want to believe that maybe a result, one finding out of a 120 gene panel, well, that's got to be the reason. And we have to be careful about that because it's most often not. Most VUSs are reclassified as normal. So that's a particularly careful result. I'm not uncomfortable with it. I think that as long as patients and families understand that that result is not confirmed to be the risk factor, but that we will continue to follow it. And sometimes we can do family member testing on family members that have some clinical manifestations of HCM or arrhythmia disorders, where we can then use that information for segregation analysis, which provides information to the laboratories to help actually reclassify those things. So sometimes family member testing is helpful. I do not recommend doing predictive carrier testing on family members generally for a variant of uncertain significance, because there's quite a bit of concern with doing that. We don't truly know that that result is the answer. And whether or not the family member carries it is also not particularly helpful. If they don't carry it, that doesn't mean they're not at increased risk, and they may avoid very important screening that they should be having. So there's some careful conversations with patients about that. I thought I would share, I know Bipul touched on this a little bit, but I thought I would share the screening recommendations from most of the professional cardiovascular societies, which suggest that at the time of a family member diagnosed with HCM, if it's a genotype positive family and there's a concerning family history of early onset HCM, screening, clinical surveillance and screening is recommended every 1 to 2 years. For genotype negative in children and adolescents, that screening usually begins around age 10, but no later than puberty. And then for adults where the genetics are normal and the clinical phenotype may be more mild, that screening, as Dr. Bipop said, is every 3 to 5 years. So one of my favorite quotes about genetic testing and the work we do is up at the top, and I can't see it because of my screen problems. But I think that it's important to know where we're going with genetics in the future.
We went to a black
Some of the gene therapy and
you hit a button.
I lost it.
You hit a button.
Sorry, guys.
we
I'm
lost
really
you
bad
also.
at technology. I promise I'm better with patience
better
and
at
having
using
these hard
technology.
conversations.
You want to try to do the screen share again? Or do you want
Still am not hearing you.
Ooh, okay. So somehow we've turned off your audio as
Which
well.
is very strange.
So I'm going to have Stacy give you a phone call and walk you through it.
I'm not hearing you.
I know. We're going to have, it's okay. It's okay. We got you. We're going to have Stacy give a call. Stacy's going to call you. And we're going to walk you through it. So while we're working on that technical problem, I'm hoping Stacy's hearing me. Stacy, are you hearing me? Okay, so Stacy's calling you. And we're going to try to get this back online in just a second. And thanks to the magic of editing, in the next edition, this will not exist on YouTube. So we will get past this. So hopefully your phone is ringing and Stacy's calling you. Okay, technical
Hi.
difficulties.
I'm back.
You're back. Can you hear me?
Yes, I can. And it could be because I'm hiding in the basement from my 3 children and dog.
It could be bad internet. It could be bad internet.
It could be.
Did you want to try to do a screen share again, or did you want to talk over those last couple of slides?
Apologies. I do want to hit that last slide because I really do want to highlight that last slide.
Okay, let's bring her up. So
Look at me go.
you got this now. You're an 8.
Can I start over? No, you don't want to hear me anymore. But anyway, future directions. So where are we going? I don't know where we're going because, okay, I lost you again. All right. Guys, this is not supposed to happen. I think we'll continue to identify more and more mutations. That's going to be helpful, clearly. The genes don't change, but the science and our understanding of the genes will change. We will continue to learn more and more. We will hopefully be able to stratify patients based on genotyping, which will be helpful for our colleagues that are managing these patients. And then, of course, the targeted therapeutics, which we're already seeing even in cancer genetics, have come a long way with tailoring and personalizing our treatments based on the actual genotype. So I think that's promising and hopeful. And then there's a whole host of patients out there that we call previvors, right? They're able to be diagnosed genotypically with risk, but they don't have disease. And I think that population is very important, that we will be doing a lot of work with how are we going to be able to possibly avert disease or improve outcomes in that population. Gene therapy, I'm not going to touch because I think I'm going to leave that to the people that are, much, much smarter than I am. But obviously the goal of being able to get in there and correct gene mutations would be fantastic and would be wonderful to see. I let at the bottom, there's a portal that I think is important. I usually share this with patients where they can go, actually a place that the NIH has funded, where patients can go and enter their particular mutations and share family history and collaborate with other families that have mutations. This helps the scientific community move the genetic information forward, because much of it is done at different labs, and whether or not the labs cooperate and how much we can get together and understand the genetics with respect to the health and the outcomes of patients. So those places and those things that we do are helpful. So I think that's all for me in my technological blunder.
You did it.
I appreciate your kindness and help. My screen sharer. I'm going to stop sharing my screen. Okay.
You can stop sharing the screen and the rest of the faculty can come join. We do have a couple of questions for you, and there is a question here that is really more of like an advanced heart failure question. So I'm going to hold it and we can address that one after Scott's talk, because it may be answered in that talk coming up. So Jim, I see your question. I'm not ignoring you. So we have a question. Okay, so we have 2 questions now. So my genetic testing came back inconclusive. She typed this before you got to the VUS part of your talk, so we might have an answer here already. I'm aware that genetic discoveries are happening quite often. Is there a certain time frame it is suggested that I repeat genetic testing due to new discoveries? So when was the last time we had a real big shift? It's been a while, but we add little stuff on there. You want to talk about that?
It's a good question. So the VUS question, How often do you check on it, and see if there's been any updated classifications? Usually your provider, whoever ordered it, your genetic counselor, will get an update on that particular VUS classification and should be in touch with you about that. I usually encourage patients to check in if they haven't heard anything. And my line is, it could be tomorrow, it could be 10 years from now. It really just depends on how much data we have and when we can reclassify it. But the thought of how, do we keep doing more genetic testing really depends on what type of testing you had. So if you had testing a long time ago and you had 2 genes checked, or you had 8 genes checked, or you had 12 genes checked, that might be a reason to consider doing update testing, because we currently run large panels to correct for the clinical overlap. So I'm in a habit of ordering many genes, but many providers are more comfortable ordering a limited panel that is just that we know is particular to HCM.
So many people that we're working with have been around a while, and some of them may have had early genetic testing as part of a trial, as part of research. So we definitely recommend those individuals from way back when go use the new clinically or commercially available testing panels. But roughly three to 5 years, check in, talk, always ask, has there been changes? We issue a checklist to patients when they go in to their clinic appointment, and one of them has the knowledge of my genetic mutation changed at all. And patients have to engage, and they have to give the team time to go back and look at that data, because it may not be that easy to just, let me just do a Google search. It's a little deeper than a Google search.
Right, yeah. You have to go to the ClinVar database, and I think it's a good question. I do think we need to keep track of it. Many of the laboratories that do this work are also, invested in getting patients the updated information. So they do generate an update to the provider, but I always tell the patient, don't lose track of it and always ask.
So of course, Hugo has great questions. Never doubt that. How many genes are currently known to be associated with pathogenic connection to hypertrophic cardiomyopathy?
For HCM specifically, it's about 30, and that includes kiddos. There's about 1,500 mutations, last I heard. So that's 1,500 different point mutations on different genes, but about 30 genes specific to HCM. The issue is some of the other disorders that have different genetic contribution will overlap into HCM, right?
So I will take this opportunity to explain, and you'll see some material coming out on this soon. And I did a podcast last week with our good friend, Greg Ruff at the Dilated Cardiomyopathy Foundation. We are part of a genetic testing consortium to raise awareness about genetic testing. And you're going to see some materials come out from the consortium, which HCMA is a proud partner in, so that we can just start talking more about the need for genetic testing and demystify it and make it a little bit more available. We know in HCM that of the 40 to 50% that we test come back with a mutation, the majority of those are in myosin binding protein C and myosin heavy chain, but there are troponin mutations, there are myosin light chain mutations, and there are other things out there that we don't quite know yet. So it keeps growing. He asks another question. I have my opinion. I'm going to shut my mouth until I hear yours. Are genetic testing tests from direct to consumer companies reliable? And I'm going to add on to your question, Hugo, reliable for the detection of a pathogenic or likely pathogenic mutation in HCM or other autosomal dominant or genetic disorders?
Right. So this is a great question. So what is the question you're trying to answer with direct to consumer? Is it about your ancestry or is it about your health information? I would tell you that the data says about 40% of direct to consumer testing is discordant with what we find with clinical testing. So I'm going to say, no, it's not reliable. And my practice is that it's repeated. So I repeat all my direct to consumer patients that come in and say, hey, my raw data is 50 pages and I don't know what this means. And I'll say, well, neither do I, because it's not the same type of testing that we're doing clinically. They don't go as far deep into the gene. They don't have the database to understand what the results are. And it's so far not reliable.
And they do not have approval from the FDA to give information regarding disease state in the same way a CLIA-approved laboratory has the opportunity to provide clinically relevant information to a patient and their physician.
Right. So I'm glad we agreed.
Yes, we do.
Know. Yeah.
Yes,
And that wasn't rehearsed. No.
No, we did not rehearse that one at all. And Hugo didn't set up the question. So it's fantastic. It's just the way things happen here.
It's a good question, right? I get it. It's easier sometimes to get the direct to consumer test. You can order it from your computer. It comes to your house and you send it in. The problem is, how reliable is it? And what do we do? What do we do with the results? How do we make sense? So it's a good question, but yeah, there's about a 40 discordance rate with it.
So thinking genetic testing for just a moment, we are in an era where people want information quickly. They want to know what's happening, what the gene means. The direct to consumer question is challenging because people think that they know something because I did a 23andMe, I did an Ancestry, whatever company you want to pick. I don't want to pick on any one company, but we often ask people in their intake calls, have you done genetic testing? Oh yeah, I did 23andMe, I'm clear. I'm like, who told you this? Who told you this? It's dangerous. It's misleading.
Yeah, it sure is. And I think we need to be careful about that, but it's out there. I actually did Ancestry. I think it's fascinating and I think it's fabulous for Ancestry information. And I have encouraged people to do it, but not for my medical information. Yeah.
I have confirmed that I am 60% Scandinavian. I found my French blood in there and somehow I'm 0.2% Asian. Who would have thought? But
it has value. It has value. It connects people that maybe never would have been connected. It does some amazing things, but it's not prime time for directing medical care.
Exactly. Okay, we have no other questions, so we can move right on to Scott, and we're going to talk about diastolic dysfunction and non-obstructed hypertrophic cardiomyopathy, a topic very near and dear to my old heart. Puns intended.
All right, let me see if I can resume slideshow. Is it showing up a slideshow?
No, you're in edit mode. So we want to go to the bottom of the screen and go into slide mode, or we want to go up into slideshow up at the top. There you go.
Got it. All right. Welcome, everyone. Thank you for attending this awesome session. Many thanks to Lisa and the HCMA for supporting these types of events. They're amazing. And again, undeniable amount of, or what's the right word? A lot of appreciation for Dr. BiPAP and all that he does. We are all here because of him. And so without further ado, this is a tough one. Definitely got the short straw here trying to explain diastolic heart failure and HCM, because to be honest with you, like there's a lot of unknowns here, but I'll do my best to fill in what we do know. And I think it's really important when we talk about this topic is to really focus on words are really important here, because HCM, HOCM are different things. And then when you throw heart failure into the mix, is there obstruction defining or causing symptoms? Is the mitral valve causing trouble? Is it just a structural challenge with the heart itself? Are there other confounding factors? Really, really challenging. And so, again, I think it's really important to start with the basics, like defining heart failure. So heart failure is really nothing more than a clinical syndrome with current and or prior symptoms and or signs of caused by structural and or functional cardiac disease. And you're unable to meet the body's metabolic needs. So for whatever reason, your heart is not pumping enough blood to get to the organs that need it. And it must be corroborated by at least one of the following, some empiric piece of data that objectively proves there's heart failure. And that can be elevated natriuretic peptide levels. So that's a simple lab test that you can get drawn at any local lab, a BNP molecule or an NT-proBNP molecule, or objective evidence of cardiogenic, meaning a cause from the heart of pulmonary or systemic congestion, so extra fluid somewhere in your body. So there has to be syndrome of symptoms plus some objective piece of data that proves that this is heart failure. And I know that may sound, overly simplified, but it's really important that we get that straight, particularly when we're dealing with a disease like HOCM or hypertrophic cardiomyopathy in general, because we don't want to miss things like obstruction that can be alleviated through vastly different means than the stuff that I normally do as a heart failure study. We also talk a lot about stages of heart failure, and I really like the staging concept because it kind of puts you on a certain pedestal, and you can certainly advance through these steps, but you can't go backwards. So once you reach stage C, there's no going back. You can't become a stage B patient. And unfortunately, stage A really reflects probably the overwhelming majority of Americans, sadly, just because it's based on risk factors. So people that are at risk of developing heart failure. And quite honestly, I would lump almost any patient with HCM into stage A heart failure. You are at risk of development. Doesn't mean you're going to get there. Doesn't mean you'll ever have symptoms. Doesn't mean you have to lay at night worrying about it. But certainly having a disease that can cause structural heart damage puts you at risk for heart failure. And in many cases, unfortunately, stage B is you have no signs or symptoms of heart failure, but there is evidence of structural heart disease. And reality is most patients with HCM probably are either stage A or stage B. Because if we're finding signs of or evidence of structural heart disease, either on echo or on MRI, or elevated biomarkers or abnormal cardiac function through other means, you're going to fall into this category stage B. And again, it doesn't mean that you lay at night worrying about what's going to happen to you in the future. It means that we're in tune with it, that you're going to a center of excellence where someone like Dr. Bivhaf can watch you very closely and make sure that we are addressing all the risk factors that need to be addressed, that anything that is reversible is being reversed, and that if it's not reversible, we're tracking it closely over time to make sure that disease is not progressing. As a heart failure specialist, the majority of patients that I meet and my team meet end up being stage C patients. And so these are patients that have structural evidence of heart disease and now are presenting either active symptoms or prior history of symptoms of heart failure. And again, caused by either a structural or a functional cardiac abnormality. And again, that's a very open-ended statement. It can reflect a number of things. Obviously, we're going to focus a little bit on hypertrophic cardiomyopathy. And then stage D is severe symptoms. So refractory to therapy. And it's time to start thinking about advanced therapy options, i.e. a heart transplant, perhaps clinical trials, and sadly, in some cases, perhaps palliation, less so in the hypertrophic cardiomyopathy population, but certainly in my older diastolic heart failure patients and systolic heart failure patients, patients that have advanced to the point where there are no other therapies offering them. And it's important that we hone in on symptom management, comfort, and making sure we're addressing some of the psychosocial challenges that come with advanced disease. And then lastly, there's a classification of heart failure. And this is probably the most simplest way to think about it and how historically we've always thought about heart failure. It's getting an echo picture and looking at the ejection fraction and estimating the ejection fraction. Or with the modern era of MRI, the computer can calculate a very accurate ejection fraction for us. And this is probably the most simplistic way to think about it is, do we see the heart squeezing properly? Does it have a normal ejection fraction? Or is the ejection fraction reduced? And so heart failure with reduced ejection fraction, historically, we've referred to it as systolic heart failure. So systole is the act of squeezing. A newer entity in the modern definition of heart failure is this heart failure with mildly reduced EF. So we always think of reduced ejection fraction of less than 40, preserved ejection fraction greater than 50. And there was always this gray zone where we didn't know what to call it. And so now the proper terminology is heart failure with mildly reduced ejection fraction. And then where HCM really falls when you start developing signs of heart failure is most of the time it's with preserved ejection fraction. So a normal ejection fraction by echo, and yet having all the hallmark signs and features of heart failure. And then for patients that have reduced ejection fraction, there's a separate carve out. Is your ejection fraction was reduced at one point for whatever reason, and with hopefully good therapies or good treatments or whatever happened, your ejection fraction improved significantly. And so we now label that as heart failure with improved ejection fraction, and that's a whole nother talk. So what are some signs and symptoms of heart failure with preserved ejection fraction? Certainly the most common one is dyspnea or shortness of breath. Again, as you can imagine, there are probably 1,000 diseases you can look up that cause shortness of breath. I tease my patients and also my mom for being Dr. Google sometimes, and you can Google shortness of breath, and again, you could really lay at night worrying about which one of those diseases you have. And so the shortness of breath that you may be experiencing is not necessarily heart failure. However, it's in the differential, and certainly if you have hypertrophic cardiomyopathy and you've been ruled out for having obstructive disease, then and you're becoming more short of breath, it's something that should be evaluated further. We'll leave it there. Other symptoms that are very common is paroxysmal nocturnal dyspnea. So you're laying at night, sleeping, you're sound asleep, and all of a sudden in the middle of the night you wake up coughing, short of breath. You have to sit up. You have to get out of bed. That can be a common symptom from fluid overload at nighttime. There's reasons physiologically why it happens. That's a very sudden, draws you out at night. Orthopnea is another nighttime symptom. So anytime you try to lay flat in bed, you're unable to lay flat. You get acutely short of breath being able to lay flat. So if you have to sleep in a hospital bed, if you have a wedge underneath you, if you're stealing pillows from your significant other and wedging them underneath you to stay up, or if you're no longer sleeping in bed and going to a recliner because you are a lazy boy, because you can't sleep in your bed, that's orthopnea, and that's usually a pretty sensitive and specific symptom for heart failure. There are some other things that can contribute to it, but that's certainly one that we worry about. One of my favorite terms, bendopnea. So you bend over and you get short of breath as you're coming up, or you get a little dizzy or lightheaded. Again, not necessarily always heart failure, but a very common symptom for patients that have heart failure. And again, beyond the scope of this talk, but certainly some physiologic reasons within your vasculature why that may happen. Swelling and edema, particularly in your lower extremities and your abdomen being bloated, can be markers of heart failure. And particularly with hypertrophic cardiomyopathy, exertional chest pain. So we always think of chest pain as having coronary artery disease and perhaps having a heart attack or having blockages in your arteries. And oftentimes patients, particularly with hypertrophic cardiomyopathy, may develop exertional chest pain that is unrelated to large vessel coronary disease that we associate with stenting and heart attacks and bypass surgery. A lot of times there's microvascular dysfunction. The small, tiny blood vessels within the heart muscle may be affected by the hypertrophy, causing exertional chest pain. And so these are, again, no single symptom here is going to seal the deal on a diagnosis, but certainly if you're presenting with several of these symptoms, a light bulb should go off either in yourself or in the providers offering care to you to make sure we screen for this and do a due diligence to make sure we've identified it. So HCM plus diastolic heart failure. Again, HCM is, we always, Bipul, Dr. Bife have shared several examples of septal disease, and there's apical variants, and there's a lot of well-described diseases that or presentations of hypertrophic cardiomyopathy. But I always think of it as a heart failure specialist that it's really not a septal disease. It's actually like a myocyte disease. You have to really get down to the cellular level and even at the molecular level to think about this disease. So it's very easy, to look at an echo and say, oh, the septum is thick. This may be hypertrophic cardiomyopathy, and certainly that is a component of it. But by the time you're meeting someone like myself as a heart failure specialist, I'm now thinking more at the cellular level of what's going on beyond that septum. A lot of patients obviously will present with a typical outflow obstruction, and once you alleviate that outflow obstruction, symptoms are relieved. But in a small cohort of patients, epidemiology is tough to gauge, but somewhere between 5 and 10% of patients, perhaps a few more, have this pernicious or progressive course of disease that lends itself towards heart failure. And it's really important to think about it is that, again, if you were to take a biopsy sample, which I've shown here on the bottom of the screen, the first sample here, you see a nice linear array of cardiac myocytes in a nice sequenced row. And that's what a normal heart muscle should look like. However, in hypertrophic cardiomyopathy, no matter where you sample within the left ventricle, even beyond the septum, you see myocardial disarray, meaning that basically the myocytes are all twisted amongst each other. There's no linear organization to it. And obviously the cell muscles are thicker. And at the molecular level, there are a lot of things that are happening that cause that appearance. But this causes a lot of challenges. Because of the myocardial disarray and the lack of organization, believe it or not, the microvasculature, the little capillaries and little arterioles within the heart muscle actually get squeezed in between those things. And so that hypertrophy actually compresses the microvasculature. There's a lot of endothelial dysfunction. So the small, less cells that line the arterioles don't function the way they should. And so it's not uncommon in diastolic heart failure linked to hypertrophic cardiomyopathy to actually have exertional angina as being a predominant symptom or a larger symptom than we would normally expect in other patients that have heart failure. So that's some of the physiology why that may be. Diagnosis, this is the hardest part, and this is, obviously we have a vested interest and it behooves us to argue this point. And again, kudos for Lisa and her organization for helping. But you need to be evaluated in the right place at the right time to seal this diagnosis. Because a lot of patients either get misdiagnosed, mistreated, or the disease is just missed. And history is everything. Actually talking to the patient and finding out, like, tell me what happens when you go to Walmart or Target, or when you go grocery shopping, or when you try to carry the laundry up a flight of stairs. Simple questions like that can really tease in what's causing here. Very simple question. How many times has a physician or a PA or an NP or a nurse asked you, so tell me about your sleep habits. Are you sleeping in a bed? Are you laying flat in bed at night? Just a couple, questions over the course of 5 minutes can really tease out what's driving this and what the etiology of the disease is before I've even done any testing or imaging. But in hypertrophic cardiomyopathy patients, it's really important. And again, this is where Center of Excellence comes in, is, it's never me looking at an echo or me looking at MRI by myself and assessing the patient. It's me going to Dr. Bipav or Dr. Depta or one of our surgeons saying, hey, let's look at this image together and really make sure that have we done a thorough job of making sure there's no gradient, because a gradient is something that we can fix easier than I can with medications and other therapies. Have we definitively ruled out ischemia? Yeah, you have hypertrophic cardiomyopathy, but you may also be a diabetic. You may have smoked in the past. You may have picked up a few bad habits. Are you at risk for coronary disease, and is that not being diagnosed or not treated appropriately, and perhaps that's contributing to symptoms? Do you have other diseases that can cause shortness of breath? So not every patient comes in a nice package deal and says, hey, I have hypertrophic cardiomyopathy. They may also have COPD or asthma or other lung diseases or other diseases that can cause shortness of breath. Again, certain risk factors have their own contributing factors. And what's really important is getting more data. And so when the picture is not crystal clear, when we're not 100% sure that we've eliminated that gradient, where we're not sure that mitral valve looks rock solid normal, is making sure we take a few extra steps and a few extra tests to really evaluate and realize and ensure we ruled out the obstructive part of HOCM, of hypertrophic cardiomyopathy. And we're really truly at this point dealing with diastolic heart failure. And that may entail a right heart catheterization. We have a recumbent exercise bike in our cath lab. And so when we meet patients with hypertrophic cardiomyopathy, not only are we in the right heart cath, but we're actually hooking them up to a bicycle and having them pedal on that bike to see what the pressures are doing inside the heart and lungs with exercise. And sometimes that can really help us tease out what's driving symptoms and what's driving the physiology. Making sure the MRI was done to protocol, particularly if it wasn't done in our center. One of the first things we do is we get the disc and me and Dr. Bipav look at it and we say, hey, they left off like half the sequences. They didn't do a good job with their gadolinium. What's missing here? Do we have to repeat the MRI and take a closer look at things, making sure we're not missing some other disease, or maybe they haven't measured the septum accurately, or the degree of hypertrophy and fibrosis. Provocative maneuvers are really essential with this disease state, particularly when we're trying to tease out obstructive disease from straight up diastolic heart failure. And so again, exercise on the cath lab table, an exercise echocardiogram with either a bike or a treadmill. And we do a ton of cardiopulmonary exercise testing. If anybody's ever seen the Gatorade commercial with LeBron James and he's got like the big face mask on and he's on the treadmill, looking like he's running a marathon, that's cardiopulmonary exercise testing. And it really teases out a lot of physiologic changes that happen with exercise and helps us determine the limitations of your heart, the limitations of your lungs, how deconditioned you are, how much your muscles are no longer working because you perhaps have been sick for a while. So cardiopulmonary exercise testing or CPET testing can really help in some of these more challenging cases. And it also helps us risk stratify. So not only can it seal the diagnosis, but if we're starting to think about, like, are you really sick to the point where you need a heart transplant? Should we be thinking about escalating therapies? Things like provocative maneuvers and exercise testing can really, really help risk stratify patients and help us tease out like what trajectory you're on with your disease. Treatment, that's the hardest part. And obviously, I spent a lot of time on the first part because we have a lot of data there. The treatment is challenging because there really are no discrete studies looking at isolated hypertrophic cardiomyopathy induced HFpEF. There's lots of HFpEF for diastolic heart failure trials, and there's lots of HCM trials, but there really aren't a lot that have looked at exclusively diastolic heart failure and HCM. And I think we're getting there. And I think that you can extrapolate some data from some of the trials that have been done. But it's really hard to assume that just because a diastolic heart failure trial is positive, that if I throw that same drug into a hypertrophic cardiomyopathy with HFpEF, we're going to see the same results. We're not there yet. And that doesn't mean we don't try, and that doesn't mean we don't talk about it. But it's really important in this disease state more than almost any other to really have an individualized approach to each patient. Look at the physiology, look at the hemodynamics on the right heart cath, look at the imaging data that you have, look at your cardiopulmonary exercise testing, and really figure out where that individual is on the spectrum of disease. How much of a risk should we be taking with a therapy, or how sick is that patient? And maybe we shouldn't be, messing around with a pill. Maybe we are at the point where we should start be thinking about transplant or something of that nature. And so really, when we meet these patients, it's really it takes a village to identify what are the risks, what are things that we can mitigate, what are some things that we can fix, and what are some things that we can't, and where do we go from here? Really important to take that approach. As a general approach, obviously blood pressure is front and center. If you look at the guidelines for diastolic heart failure, it still is the only really true class 1A recommendation, the highest level of evidence with the best data behind it. Good blood pressure control can definitely help offload the ventricle and make it easier to pump. So good blood pressure control, we always start there. Management of comorbidities. I run a cardiometabolic center. I do a lot with diabetes, making sure that we've addressed other risk factors and other things that we can actually manage. Weight loss is a huge one. I'm sure we'll get into that a little bit on the next slide. But weight loss is a big one. Addressing obstructive sleep apnea, getting pulmonary function testing, looking for areas that we can improve stuff, knowing the challenges that we have with hypertrophic cardiomyopathy is very important. And certainly optimization of volume status. Anyone on this call that's suffering with diastolic heart failure from hypertrophic cardiomyopathy understands the concept of making sure you're dry, trying to find a balance point between your renal function and your heart function, and making sure you don't affect your kidneys with diuretics can be a huge challenge. I think right before I hopped on, there was a question posted about the growing role for SGLT2 inhibitors, angiotensin receptor blockers, ARNIs, angiotensin receptor blocker, neprilysin inhibitors. So for the lay public, whoever's on this call that's not directly tied to medicine, so Jardiance, Farxiga, they advertise on TV a lot. ARBs would be things like valsartan or losartan, anything with an ART in. And then ARNI, the only FDA approved one is Entresto, is the trade name. We don't know. The ARBs have been looked at in the past with hypertrophic cardiomyopathy, not specifically diastolic heart failure. It didn't really show a huge improvement in outcomes. Again, but they didn't really tease out just diastolic heart failure. They were just looking at a broad spectrum of patients with hypertrophic cardiomyopathy. So we don't have great data for ARBs. I am pretty liberal with my use of SGLT2 inhibitors in HOCM patients or in HCM patients with diastolic heart failure. Again, carefully, cautiously watching, renal function, volume status, things of that nature, being very clear to my patients that this is, I'm not gonna say it's off label, but we don't have great data that it's catered towards hypertrophic patients. But certainly there's a robust amount of data in diastolic heart failure. And so it probably plays a role. And certainly if it's well tolerated, it's a pretty benign drug. It doesn't have too many side effects. Certainly if you're a diabetic or have other reasons to be on the drug, that makes it nice to use it for those indications, perhaps with some added bonus. Mineralocorticoid antagonists, so spironolactone and eplerenone is another class of drugs, hasn't been well studied in hypertrophic patients. However, there's a robust body of literature in diastolic heart failure patients that perhaps it plays a role. And again, so if the renal function is acceptable, potassium levels are okay, all the things that we would monitor in patients on these therapies, we'll have that conversation. We'll say, why don't we give this a shot? Downstream effects of mineralocorticoid antagonists, they seem to reduce a lot of the fibrosis pathways that we see in a lot of later stage hypertrophic cardiomyopathy patients. Again, has it been studied directly? No, but anecdotally, and if you extrapolate from other cohorts of patients, perhaps it plays a role. Dr. Bipap pushes beta blockers on every single patient that has obstructive disease because beta blockers can lower that obstruction. But once you shift your physiology from obstructive to non-obstructive and you become more of a diastolic heart failure patient, I generally hate beta blockers. That's a strong word, but I generally avoid using beta blockers in diastolic heart failure. They're not well tolerated. There's a lot of physiologic reasons why they may not be the ideal drug. And so again, as your disease evolves over time from obstructive to non-obstructive, is it time to remove that beta blocker or cut back that dose? Perhaps your physiology has changed to the point where you shouldn't be on that higher dose. And this gets really back into that tailoring the therapy based on your physiology, not looking at a population of 1,000, looking at an N of 1 and how to treat that one patient. I'm sure everyone on this call is very familiar. I think it's been all the news. There was a lot of spelling errors here. My slides, I apologize. But mavacamten is the new kid on the block. It's kind of the hot new experimental therapy for reducing, not really experimental anymore, FDA approved, for reducing obstruction. They haven't looked at it in diastolic heart failure. I put up this one slide because it's kind of thought provoking. So one of the one of the clinical endpoints of the trial was to look at NT-proBNP values with the use of the drug. We use NT-proBNP in all kinds of cardiac trials because it's a great marker of wall stress. When the left ventricle is under duress, when it's being worked too hard, it secretes NT-proBNP to try to relax things. And so the higher your NT-proBNP goes, the more stress wall the LV is under. And so you can see here in patients that got the drug, which are the blue and the red lines here, there was an overall downward trend in NT-proBNP values compared to the patients that did not get the trial drug. Again, it was not looked in diastolic heart failure. I think that's one of the next steps with this therapy is thinking about, this drug helps the myosin chains actually cross-link and reduces the myofibril disarray, if you will, the lack of cross-bridging. And so in a diastolic heart failure patient that has that challenge, perhaps this drug could play a role. We don't know. Still very experimental, but again, thought-provoking, and it kind of hopefully gives you a glimmer of hope that we're starting to crack some nuts here with this disease and the challenges with diastolic heart failure. There could potentially be a pathway forward with some of the newer drugs for obstruction may work in non-obstructive diseases. We just don't know that yet. I'm a big believer in using experimental devices to help patients that don't have any other options. When done properly and carefully, and we make sure we have the right therapy picked, it can be helpful. Unfortunately, a lot of the diastolic heart failure trials, they don't necessarily, they're not inclusive, but they're also not exclusive of hypertrophic cardiomyopathy. In general, as long as you're labeled as non-obstructive disease, we oftentimes can get patients with diastolic heart failure and HCM into clinical trials. So this first device here, purple, is an interatrial shunt. There's a couple of companies out there that are using devices in clinical trials. Most of the trials have completed enrollment, and we're now in that waiting period looking for data. We ourselves have enrolled a couple of patients with non-obstructive HCM into this trial. Again, we don't know if it works or not, but it certainly has some potential. The idea of putting a little hole in the heart is it's a pop-off valve. So as your left ventricle builds up with volume and pressure, next chamber up is your left atrium. Now that chamber has to accommodate the excess blood that has nowhere to go, and so it backs up into the lungs and makes you short of breath. So the idea of making a small hole here is that a little extra blood can squirt back into circulation and bypass the lung circuitry, and perhaps not get you a short of breath, particularly when you exercise. We just don't know. That's the honest truth, but certainly thought-provoking. The trials are underway. Again, they've all enrolled. And again, our center had a couple patients. I imagine a few other centers had some patients with HCM enrolled. And so perhaps if we're lucky, perhaps a subgroup analysis or a post hoc analysis of those patients, we can tease out whether there may be some benefit for patients with HCM. Another interesting idea is that there's these nerves that run through your pulmonary artery. That's the artery that comes out of the right ventricle and goes into the lungs, brings deoxygenated blood into the lungs. You have all these baroreceptors that sit there that are innervated by the sympathetic nerves. Your sympathetic nervous system makes heart failure worse. It gets revved up and secretes a lot of adrenaline and puts a lot of stress on the heart. Downstream, over years of upregulation, causes a lot of fibrosis and scarring of the heart. So this was just presented 2 days ago, actually, in Boston at an awesome heart failure meeting that I was part of. And they presented data, basically ablating these nerves in the pulmonary artery and blocking that sympathetic drive in patients with bad heart failure. And there's a signal there. It was a very small trial. It was only done with about 10 or 15 patients. But there was certainly a signal that perhaps these patients responded really well to having suppression of their sympathetic drive through their pulmonary arteries. And again, so the hopes is that trial was performed in China. There's hopes that the doctor that invented the procedure and invented the catheter used for this procedure presented. We're hopeful that in the next couple coming months, that trial may start to enroll in the US perhaps. And so again, it gives us hope that there are therapies on the horizon that may help patients that have advanced diastolic heart failure, hopefully regardless of the etiology, for feeling better. And then the last kind of semi-experimental data is for GLP-1 agonists. So GLP-1 agonists are all the rage. Elon Musk is on them. A lot of celebrities are on them. Anytime you pick up page 6, you can see comments about celebrities that have lost 20 pounds, and it's presumably because of a GLP-1 agonist. So on TV, you'll see Ozempic, Mounjaro, Trulicity. There's about a half dozen of them on the market. GLP-1s are working themselves up to be perhaps somewhat of a wonder drug, not only for weight loss, but they also do a lot of other interesting physiologic changes in the body. They change metabolism. They allow the heart to suppress fatty acid metabolism. So almost like a fasting state. The heart works more efficiently depending on what nutrition it's using for metabolism. So in addition to weight loss, in addition to good diabetes control, they also may play a role in fatty liver disease. There's a thought that they may actually help diastolic heart failure patients. And so there are currently several trials, one of which we're part of here at RGH, where if you meet certain criteria with diastolic heart failure, you can actually be enrolled in getting a GLP-1 agonist. And hopefully over the course of a couple of years, we're going to see if these drugs actually, not only do they help you lose weight and some other benefits, but do they actually help heart function? Do they help heart recovery? Do they improve symptoms and hopefully survival? There's a lot of ideas and concepts that make a lot of sense on paper. Whether this plays out clinically, we just don't know. But again, we're very optimistic and hopeful that there may be a role for drugs like Ozempic and Mounjaro down the road. But again, when we have so little else to offer patients, clinical trials can be a huge opportunity to not only help yourself, but also help future generations improve their lot in life. So that's just some teasers about what's out there and where we're at with therapies. And then lastly, as Lisa can attest to, sometimes none of these therapies work, or you're too advanced in disease, and we really have to start thinking about transplant. And so for very advanced disease with progression of symptoms and not tolerating therapies and just no quality of life, a transplant is a very viable option. Luckily, it's a very small percentage of patients that have HCM that need to progress towards transplant. The challenge, and one of the reasons that HCMA is so important, is that oftentimes the patients that need it most are usually the last to meet a heart failure doc that can get them on that path. And so advocacy and paying it forward and going out there and advocating for patients that have HCM to be plugged into the right centers, so that if they are really advanced and there is no other options, that we can offer them things like a transplant. Left ventricle assist device. So if you're not a candidate for transplant, is an LVAD possible? It's been done. There are case reports. I've been involved in a few cases. LVADs are really challenging because of the physiology of HCM. The ventricle size tends to be a little bit smaller. The cavity is a little bit stiffer, or the LV is a little bit stiffer. These pumps work by sucking blood out of the cavity into circulation. So having a nice dilated ventricle where the pump can fit in there nicely and suck down plenty of blood works well. These small, stiff ventricles that HCM patients often have is not oftentimes conducive. But if there's no other options, you're a very young patient, for whatever reason, you're not a candidate for transplant. There are definitely case reports, and again, a couple centers, ours included, have off-label and looked at these options if there's nothing else we can offer someone. So again, it just goes to show that if you go to the right center and you get plugged into the right people, sometimes what may not be deemed an option somewhere else, sometimes you can find a path forward to keep people alive and improve their quality of life, which is both very valuable options. And so with that, I will stop rambling. Hopefully I'm on time here. Yeah, there's my contact information if anybody has any questions or concerns.
Thank you very much. We are running a little bit over tonight, so I'm going to be really quick and we're going to do rapid fire questions, and then we're going to get to Jeremiah's talk. So you addressed Jim's earlier question about Entresto, Jardiance, and other classes of drugs being used in hypertrophic cardiomyopathy. And I think you handled that quite nicely, so I don't think we need to belabor that question any longer. Jim, I hope you found that useful. So how do SGLT2 inhibitors relieve the pressure within the heart? Does anybody really know yet?
Yeah, so I have to be careful. This is being recorded. Who knows who's going to watch it down the road? There's a lot of theories. We'll start there. There's definitely some theories, and we have some idea. The drug definitely has some mechanism of action through the kidney. It clearly lowers glomerular hypertension. So a lot of patients with heart failure and volume overload, their kidneys tend to suffer significantly, and there's a lot of pressure, extra fluid getting pounded into the kidney. There are some proposed mechanisms to how that helps alleviate pressure in the kidney. And downstream from that, if the kidney, the kidney is a filter. I always think of the kidney as that's really what it is, a filter. Filters need a lot of flow, so filters need your kidneys take about 40% of your cardiac output with every cycle, and so whatever allows more blood flow through the kidney can often then downstream send a signal to the heart and tell the heart, hey, we're getting plenty of blood flow down here. You can kind of calm down and relax a little bit. So probably through the kidney, it decompresses the heart. But it has a lot of other roles. It seems to induce blood cell production. So there seems to be a signal that your hemoglobin, hematocrit levels climb. Hemoglobin is oxygen carrying capacity. So if your blood tissue is if oxygen is getting to your tissue, it probably sends a downstream effect to the heart that doesn't have to work as hard. So again, there's a couple of proposed mechanisms. There are metabolism things that it does. It shifts metabolism in the heart into a semi-fasting state. It improves the ability for the heart to use free fatty acids and glucose. So lots of proposed mechanisms. If I give this talk in maybe 3 to 4 more years, we'll probably have better insight as to why that works. But lots of, probably about 10 to 15 robust trials now demonstrating across the spectrum of heart failure that SGLT2 inhibitors play a sizable role in helping patients across the spectrum of disease. Nothing specific to HCM, but enough signals there to think that it's at least worth a shot in a lot of patients.
So I have a question, and it's a loaded one. So Bipple, you might want to put yourself off of mute as well. If you relieve obstruction, will that eliminate diastolic dysfunction and heart failure?
People, you want to answer that first, or you want me?
So depends. What we've learned is, and this is through some of the septal myectomy trials and stuff, where people have pulmonary hypertension, and obviously diastolic function is playing a role, and then the good septal myectomy with no residual obstruction actually alleviates pulmonary hypertension. And sometimes even with patients with obstruction, sometimes the obstruction component may be the lesser component and the diastolic component is the bigger component, especially if they have a lot of thickness, if the cavity is small. And some of those patients, even if we do septal reduction therapy, may not feel that much better, but it's a small proportion of patients. From experience and from literature, what we know is that if you have significant obstruction, relieving the obstruction will improve symptoms in a vast majority of patients. But there are always that, maybe 10, 15% who may not feel better. Then
Right.
The other odd thing also is patients who had a septal myectomy at suppose 30 years of age, but now they are 50. And so the natural course can be very variable. And now they're struggling with diastolic dysfunction. So it can be very variable.
Right. And it's, again, Bipple refers to me when he meets a patient who comes to him and he says, oh, this is more heart failure, not HCM. And vice versa. Sometimes we get referral to our clinic for diastolic heart failure, and we look at this and we're like, oh, this is undiagnosed HOCM, like obstructive disease that's been missed. And that's really why it's so important I never, ever, for my entire career, I've never looked at an echo report. If I don't have images, it's like the report means nothing to me. And so it's really important if you're being referred to another center, is tracking down that disc or just repeating the echo yourself, and really teasing out, making sure. And so, I'm sure I guarantee there's probably someone on this call who's been through more than one myectomy because they went to one center or one place and they were told that, oh, everything's done. And then sadly, we take another look and we find out that they didn't do a good enough job. And there's various reasons for that. I'm not blaming a surgeon or whatever, but the reality is that sometimes it's not HCM with diastolic heart failure. It's still HOCM that either we didn't do enough provocative maneuvers, the surgical or alcohol septal ablation wasn't thorough enough, varying things of that nature. And so it really, again, it comes back to, this is not a disease state where I just throw someone on an SGLT2 inhibitor and an Entresto and I pat myself on the back and send them and see them back in 6 months. The first encounter is, let me get your echo, let me track down where you had that MRI done, let me review it with Bipple. And if we're not happy with the quality, we go to bat with the insurance company and we say, look, it's got to be we'll tell the insurance company, don't pay for the one that you had done at the other center. It was a crappy study, plain and simple. And it has to be repeated. I can't help it. They didn't get the data we needed. It's got to be repeated. Again, first and foremost, my job number one as a heart failure specialist in HCM is to make sure there's no obstruction and the mitral valve is looking okay. Once I've ruled out that definitively or as best to my abilities, then we can focus on the diastolic heart failure component of it. But it's really important to take that approach.
Okay, the last question, and we're going to move on to Jeremiah because we're running late, and we'll answer the rest of the questions at the closing session. Are there plans to add a transplant program to Rochester Regional Health.
Oh,
I'm wondering, because I see that they're now a center of excellence, and will that help them make the decision to add transplant?
so anyone who lives in New York State, get on the phone with your local representatives and Governor Hochul. New York State is a certificate of need state, and certificate of need means that the Albany, the government as a whole, has to approve any expansion of any kind within healthcare. And unfortunately, when you look at a map in New York State, you have about, I don't even know, a half dozen to a dozen transplant centers. And then you cross the Hudson River and you have Westchester and the U of R, and there's a huge swath of a couple million people that have really very little access. There's actually there's actually a great paper published 2 years ago, maybe 3 years ago, that looked at cities that had multiple transplant centers, and outcomes are better when there's multiple transplant centers because competition makes everybody better. I mean, you can take that approach with everything in life. But right now we cannot be a transplant center because the bureaucrats in Albany will not allow us to be one. We would love to be one. Get on the phone and start advocating. It's not just transplant. There's, if you have to travel 5 hours for an MRI, it's probably because your local hospital is not allowed to install an MRI machine because some other entity is not allowing the hospital to invest in an MRI machine. Certificate of need really holds back care for a lot of regions. It's really a challenge.
Okay.
Yeah, I'll get off my soapbox.
Thank you. No, but that was a very good answer. And this is where advocacy comes in. You need a voice.
Right.
And you need to know what the problems are. We will get to the rest of the questions before we conclude tonight, but without further ado, Jeremiah, you're up.
All right.
And look at that screen share. He's on it.
Are we all good?
You're good.
Perfect. It's a real pleasure of mine to talk to everybody tonight. I really, really enjoy the patients I get to meet when involving valvular heart disease and have hypertrophic obstructive cardiomyopathy, and working with our clinic here with Dr. Byboff and Scott and the whole team. You guys are such informed patients, and it's a real pleasure to try to do what we can to help out. We thought of this topic because Dr. Byboff and I have noticed that I wouldn't say an epidemic, but not an uncommon occurrence, especially in our older HCM patients, that they have both HCM and aortic stenosis, and these are really partners in crime. And how do we manage it? These are my disclosures. So a little bit about aortic stenosis. Aortic stenosis is a progressive condition that predominantly, especially in the United States, results from buildup of calcium on the valve and causes the valve to narrow over time and obstructs the blood flow out of the heart, the same as hypertrophic obstructive cardiomyopathy, and will cause essentially the same symptoms that you will find in people who do have an obstructive component of their hypertrophic cardiomyopathy. So the aortic valve is here. This is the basal septum, and you'll find that this is the same spot. So they are right next to each other. This is a very common condition in older patients. So 1 in 8 adults over the age of 75 will have symptomatic severe aortic stenosis. This is a progressive condition. It doesn't stop, it progresses in everyone. And how do we treat it today? Years ago, we'd just be saying the only option was surgery. In 2023, the majority of people are getting their aortic valve fixed by something called transcatheter aortic valve replacement. And I'm showing you a video on the left here. It used to be only done in high-risk patients, but now it is available to patients of all age. And I would say the majority of people who are getting their aortic valve replaced for aortic stenosis are undergoing this procedure where we take a stented valve and inflate a balloon that pushes the old valve up to the side. And then you have this stented tissue valve that stays into place and relieves the aortic stenosis. And pretty much you're getting an immediate relief of symptoms. And this type of procedure is done under conscious sedation. And we have patients even here, about 15% of our patients go home the same day. it is important to know that with aortic stenosis, that survival is poor without treatment. So if you look here on the right, you can see that the rate of death is happens in a timely fashion where patients, if you look at up to 3 months, that's 7.6 then, so 8% of patients will die of severe symptomatic AS, and about 11% by 6 months. If you go out to 2 years, you're looking at half the people will die, and 80% will be dead within 5 years. So when we see that people present with aortic stenosis and they have symptoms, we treat it as quickly as we possibly can. Now, back to hypertrophic obstructive cardiomyopathy and aortic stenosis. One thing that we knew when we look at the prevalence of both conditions by age, you'll see that the prevalence, meaning how often it occurs in the community, increases with age. And so aortic stenosis increases with age, and so does hypertrophic cardiomyopathy. And so they mirror each other. So this is why they co-localize commonly. So when you think of obstructive cardiomyopathy, hypertrophic obstructive cardiomyopathy, how often do patients have both conditions? I would have to say that we don't actually know. If you look at people who, and this is older surgical literature, they say that about 10% of patients who are getting their aortic valve replaced also undergo septal myectomy. Now, are they hypertrophs? Did they need it as part of the surgery? It's difficult to say. I do feel that this number is probably low, and I think this is a nice example here. Again, this is not a stenotic aortic valve, but you can see the obstructive component and its relationship to the aortic stenosis. And one thing I will also say is there's a difference between familial hypertrophic cardiomyopathy or obstructive cardiomyopathy and non-familial. And what we say, non-familial will be about 40% of patients, and it may even be higher. And what happens is, as we get older, we develop hypertensive heart disease. The ventricle obviously hypertrophies over time. And what that can happen, and this is always a question as to why it happens, but people can get asymmetric septal hypertrophy. We call it ASH or basal septal hypertrophy, or that's the potential obstructive component that occurs at the basal septum. And this can happen just from hypertension alone, and something that happens as a natural process of aging. And if you have that septal hypertrophy, that can lead to obstruction and things that you guys know very, very well in terms of being HOCM. This is from Cleveland Clinic. I'm not saying this is the truth of all, but an interesting idea is about, does aortic angulation, is it important? If you look at the angulation of the aorta as it comes out of the heart, you find that hypertrophic cardiomyopathy and people who have hypertensive heart disease, that the angle is much different compared to that. And if the angle of blood flow flowing out of the heart, if that angle is more acute, you can find that there's turbulent blood flow. If you have turbulent blood flow, you have lower pressure in that, and that can then exacerbate an obstructive component and part of the pathophysiology causing the Venturi effect and systolic anterior motion, the mitral valve getting pulled over, and people not feeling well. And even if you look here, when you look at age, that angulation in all of us will change over time. And this is some elegant studies that were done at the Cleveland Clinic years ago. So when you have HOCM and you have aortic stenosis, are they a problem together? Well, the first thing is that it is a diagnostic problem. And part of it is that aortic stenosis, being an obstruction, can actually mask the obstruction of hypertrophic obstructive cardiomyopathy. And interestingly, again, coming from the surgical literature, that about 1% of patients who are undergoing aortic valve replacement will crash, and something called ASH crash, and require unplanned, essentially emergent at the time septal myectomy. And this is animal studies, and what this is showing is this gradient. So you see these lines here. One is the aortic pressure, and the big lines are the left ventricular pressure. These gradients, so the difference between them And if you increase the afterload, so in aortic stenosis, you would increase the afterload because there's a fixed obstruction above that obstructive component in the muscle, that you find that that gradient goes down. So aortic stenosis can mask hypertrophic obstructive cardiomyopathy. But what can we do to differentiate the two? And the reality is it's really tough sometimes. We need really careful assessments with echo and TE with provocation and trying to tease this out, but that doesn't always give us anything. We can do the same with cath, where we put a tube across the heart and try to map out where is it the valve, is it the obstructive, is it both, or you can do a cardiac MRI. But sometimes even doing all sorts of imaging, it is hard to assess this and hard to diagnose. And so what do we do with therapy? You have somebody who has symptoms. We know what can happen in terms of aortic stenosis. We know about hypertrophic obstructive cardiomyopathy. Well, when it occurs together, what should we do? What should we treat first? Should we treat HOCM? Should we treat the valve? This whole idea of ash crash, I don't really love the term, but that's something that you may Google, you might hear about somebody all of a sudden, when you relieve that aortic stenosis, boom, that obstructive component comes out and people get very, very sick. Now, I will say, doing TAVR, and we're a very high volume TAVR center, done thousands of them. The idea, and we have people who have basal septal hypertrophy, the idea that somebody crashing after is a very, very uncommon situation. In fact, I have not seen this. And surgery is different. You have to think about when someone undergoes surgery, they're on the heart, they're on the pump, and then they put them back on, but volumes are different. And so in general, is ash crash more of a surgical phenomenon compared to something that might occur when we're doing a transcatheter aortic valve replacement? But it is important to think about when you're thinking about what should be done first. There is an incredible survival benefit with fixing the aortic valve, meaning that patients live significantly longer and their survival curves are dramatically different if you fix their aortic valve. So that's something to be mindful. And then also with mavacamten coming on board and changing the landscape of medical therapy with HOCM, does that change the game where we might think of doing aortic stenosis first before we think about fixing the hypertrophic obstructive cardiomyopathy? And this is a unique example. We had a patient here, 85-year-old male, severe aortic stenosis, a dentist, retired dentist, really active, progressive symptoms, on maximal medical therapy. You can see here on the left, we have our aortic valve that's not opening. You can see it here. You see that basal septal hypertrophy. I would describe this probably more in the line of from hypertensive heart disease, so non-familial, but we did not test this gentleman. Had resting gradients of 70, and then with Valsalva or provocative measures, it went up to 130. We did a heart catheterization on him. And at rest, we found the typical gradient that you would find with aortic stenosis. So a peak gradient of 68 and a mean gradient greater than 64. But then when we did a provocative measure, something where we cause an extra heartbeat, we call it post-PVC. We also find there's a provocable gradient, and you get a peak gradient that goes up to 125. So this patient definitely has both. And we decided, what are we going to do? We had a heart team discussion. The guy is in his mid-80s. His risk of dying, something we call an STS score at 30 days. So what is the risk of a patient dying with open heart surgery of getting their aortic valve fixed is 8.5%. That's high. And so the heart team felt, this guy is not the best for surgery. And we thought the best measure was to do an alcohol septal ablation. And here, if you see this, there's a big first septal. So this is the catheter into the left main and the left anterior descending artery. But these are the septal perforators that go down that feed that septal wall. Is a big first septal perforator. But when we actually teased it out, we found that this little branch here, which is now cut off after the alcohol septal ablation, was the one really causing the symptoms. And so with alcohol septal ablation, his LVOT component, the peak gradient went from 70 down to 7 following septal ablation. So a really good result in terms of the obstructive component. But the guy after it, and over that 6-month period, our patient still had symptoms, and his severe aortic stenosis only progressed. I told you earlier, it always only progressed. So then we did a CAT scan. This is a CAT scan showing the 3 leaflets of the aortic valve. You can see the calcium. We sized the valve, figuring out exactly what size valve, and we have a map from basically neck down all the way through the pelvis to be able to tell how to get the valve in. And then here we're performing aortic valve replacement by transcatheter means, and you can see we're going to be inflating the valve, and we have this pigtail there, shows where the valve in, then we're inflating that balloon, and then you'll see on this side, the valve is in place, the obstruction is immediately relieved, and we have no leak, and we had a good result. And so for this patient, his symptoms resolved. He's now walking on a treadmill for 3 miles without symptoms. His mean aortic valve gradient is 6. His peak LVOT gradient, meaning the obstructed component, is at 10, and with a provocative measure, goes up to 32. And I think compared to what he was starting with, is pretty great. And so when you look at these conditions that co-localize, increase, are very common in older patients, and it's driven primarily by hypertensive heart disease causing that asymmetric septal hypertrophy. Really, we need careful testing to help determine management. And I think, in my opinion, given the changes in medical therapy and the proven benefit of TAVR, when you have both conditions and they are severe, it may flip to where we fix the valve first and then medically optimize the patient with our current therapy. But again, that's still very debatable. So with that, I can take questions.
You know, some of you guys ramp into your, and my last slide is, and I know exactly when it's coming, and some of you pivot real fast and you get
I
it.
pivoted fast.
You pivoted fast on that one. Okay, so I don't have any pointed questions for you at the moment. So I'll let everybody collect their thoughts on that, post their questions. And Vipul, do you want to give your contact slide? And then we can get to the final questions of the evening.
So this is our contact information.
But Jeremiah's still sharing.
I will unshare. Sorry. Stop sharing. Apologize.
Okay, there you go. And
Okay.
Vipul's sharing.
So we are located in upstate New York. These are the Finger Lakes here, these blue lines that you see. So we are between Buffalo and Syracuse, but we cover a vast area. We have a dedicated HCM center line, and this is also listed on the HCMA COE registry. Christopher Rees, he does a terrific job with scheduling, so he's dedicated HCM scheduler. Ludmila Kuchma is our nurse practitioner. You can also email us at this email address if you have questions or you want an appointment. This is our website. If you just Google Rochester Regional HCM Center, it will take you to this page. We are located in Rochester, New York, on the northern side of the city. We are there for you, and we try to get patients in very quickly. So once we get your phone call, we try to get all your records. We'll usually review your imaging, as Scott said, prior to the appointment to make sure that the imaging has addressed the questions. Otherwise, we will contact you that we need some additional testing. If you've not had testing, then we will do the testing here. We try to make appointments efficient for patients who are traveling from out of town. Our HCM clinic day is Friday. So some patients who may need a lot of testing on Friday might stay in town. We also have some financial assistance where you can get discounted hotel rates and stuff, but we try to get all the appointments and testing done in a reasonably quick time so that we can answer the clinical question. And based on after initial encounter, if you need to see Dr. Depta or our heart rhythm expert, Dr. Chuprun, or you have diastolic dysfunction, you will see Dr. Feitel. And, we have a very, very great team. We talk almost on a daily basis. Everybody's very approachable, and we co-manage, try to co-manage to the best of our ability.
Okay, I thought I was hitting my chair to angle it forward and I just dropped 3 inches. So if anybody saw that look on my face, I thought my chair was falling apart. Sorry about that. Getting late in the day. So I can tell you, I have been to the center. It's a little bit far from me in New Jersey, but it was easy to get to, clean, comfortable, easy access. These are things that we look for when we go on our site visits, and we want to make sure that patients are going to have a positive experience. And I think that is definitely available there. Okay, so we have some other questions here we're going to get to real quickly. And then in just a moment, we're going to stop the share on Facebook. So that's nice. And we'll answer a couple of these questions, and then we'll turn off the question and we'll turn off the recording here as well. So Jillian, I hope you're still with us. You've been hanging for a while. So she is trying to figure out what the purpose of an implantable defibrillator is with the following story. Her dad had one put in a few months ago, and I'm reading verbatim, but he's back in AFib again and probably needs to get his heart shocked back into normal rhythm again. I thought he got a defibrillator to address this issue. Isn't this a common situation? Why am I confused? Who would like to explain to Jillian why she is confused?
I can, or Scott, you want to take that?
Sure. Yeah, so we get this question all the time, and it is super confusing. And so it's a lot, it gets back to like language, right? And using the right words. And I'm just as guilty. I'm originally from Jersey. I have a tendency of talking really fast. So my patients sometimes say, Scott, slow down, to repeat what you said. So all defibrillators have the ability to be pacemakers. Not all pacemakers are defibrillators. That's the first important distinction. So a defibrillator, I always go back to I'm just old enough to remember George Clooney in ER rushing in with paddles to shock a patient back to life. More recently, I'm aging myself. I should use Damar Hamlin as probably the more we're Bill's country up here. So a defibrillator saves your life from sudden cardiac death. That is all it does. It doesn't do anything else. So if you go into ventricular tachycardia, so a rhythm from the bottom chamber of your heart, VT and VF are the most common ones. The defibrillator senses that, it charges up the battery, and it internally delivers that jolt of electricity to save your life and get you back into rhythm. Atrial fibrillation is a rhythm of the top chamber, and certainly it can be a nuisance. Certainly it has some risks to it. The biggest one is it's the #1 reason people get strokes in the US. It generally speaking does not cause sudden cardiac death. It's relatively well tolerated, and relatively is a relative term. So defibrillators will do nothing for atrial fibrillation. That being said, if the atrial rate were to get too fast, if it goes very fast and the defibrillator can't tell the difference between VT or VF and AFib, there is the possibility of getting inappropriately shocked for it. But atrial fibrillation is a disease that we treat oftentimes with antiarrhythmic medications that can slow down the heart rate. Or sometimes there are ways to shock you out of atrial fibrillation, a different kind of shock therapy. But the defibrillator is designed and programmed to not touch anything coming from the atria. That if it's an atrial arrhythmia, there are better ways of dealing with it than having the defibrillator deal with it. So the defibrillator was placed because one of the biggest risks of HCM is sudden cardiac death. But AFib is very common, and we do not want the defibrillator touching that. You'll be walking through Walmart and getting shocked from your device. That would not be pleasant. Hopefully that answers the question.
I think it does. It is a common confusing question. When I have an implantable defibrillator, why do I have to go someplace else and be defibrillated?
Right.
But there was, I don't know if you guys remember this, there was a short period of time where there was a device that they were putting out that you would actually put a monitor, like you would read your device, and you would work with your doctor and it would shock you at home.
Right.
And there were a few of them out there in a trial. It didn't go very well. It was not.
Didn't go well. And the other challenge is every time a defibrillator goes off, it eats close to a year of battery life. And obviously anyone who in the audience who has one of those, it's not a big deal, but if you have, every time they have to cut open, take out an old one, put a new battery. So we try really hard not to defibrillate from the device anymore. And that's one of the reasons that device did not take off, is the battery life got eaten up very quickly. So the external defibrillator that we use in the cath lab or wherever it may be done, it's plugged into the wall, you have readily available electricity. There's only a finite amount of electricity stored in these batteries, and every shock eats into that. So we try really hard not to shock for atrial rhythm.
Two other comments on defibrillator and battery life. Number one, there was a thought at one point, well, couldn't I just check my device on my phone and see how it's doing? And I actually met with engineers at both Medtronic and Boston Scientific on this idea, because some patients really wanted very urgent monitoring. The amount of battery, it sucks. People would be going through 2 or 3 more devices per life. That's 2 or 3 more surgeries and risk and expense. And the value just didn't seem to pay off. And I agree. I don't think it pays off. So that's one. And number two, I learned something new about defibrillator batteries in the past week or two. Stacy will laugh at this one. So we have a couple of formerly used defibrillators in the office, most of which came out of those who were transplanted, and they donated their hearts to the HCMA for education and research. And they have their ICDs too. Even though they're turned off, at a certain point, they come back to life and they tell you the battery's dying. So Amy's ICD that was explanted in 2018 has come to end of battery life in the past few weeks. And at 3:30 every day here at the HCMA, we hear the alarm. So I didn't know that it hasn't been used. It's been turned off this whole time. But when the batteries they just deplete on their own. So it's dead, dying.
And the first time it goes off and I'm in the office with her and I have a defibrillator myself, you panic thinking it's your own device alarming.
True story. The look on her face was like, oh no. And I'm like, oh, that's behind me. That's
Like,
not
I'm
you.
only 2 years in. This can't be right.
It was a moment there, people. It's HCM humor. And if you have a defibrillator, you would get it. Otherwise, you'd be like, that's kind of warped humor. But hey, we liked Otto too. Okay. Jeremiah, we have a question for you. We actually have 2. I'm going to ask them in reverse order here. Transcatheter aortic replacement, is that considered for moderate stenosis of the aortic valve?
Not currently indicated, though we are participating in a very large clinical trial called the Progress trial, which is for people who have moderate aortic stenosis and doing TAVR and moderate aortic stenosis versus watchful waiting. So stay tuned. It's a very large clinical trial sponsored by Edwards Life Sciences. We're one of the centers that does that. So
very good. What happens to aortic stenosis if you have a heart transplant?
Well, you get all new valves, so that's cool. So you do not have to worry that if for some reason you had valvular heart disease and you got transplanted, you would typically get all new valves. That doesn't mean that you couldn't develop valve disease in your lifetime, all right? And so your transplanted heart has the potential to go through the same changes that any human heart can go through. And so you can still develop valvular heart disease. And I guess I'd even interpret the Scott a little bit. Is there, and I don't know the answer to this, I probably should, but is there, in people who've been transplanted, is there any increase in the rate of certain valvular heart disease compared to a non-transplanted heart?
Great question. Believe it or not, it's actually tricuspid disease, and that's because of pesky heart doctors like myself taking biopsy samples all the time. So every time you go in to take a sample, you disrupt the anatomy of the tricuspid valve. So tricuspid regurg is actually very common in transplant, especially in the old era. I believe Lisa actually is the only person she alluded to is out of transplant here. But nowadays with molecular testing, most patients don't need to go through biopsies as rigorously. And a number of centers actually have done away with biopsies beyond the first couple of months of transplant. So the incidence of tricuspid regurgitation has improved significantly. But if you look at literature of patients that are 10, 15, 20 years out, it's almost impossible because when you go, you can't really aim where the biopsome goes to take the sample. So it's not uncommon to destroy a little bit of the tricuspid apparatus every time you take a piece. The incidence of other valve disease is actually very, very low for a multitude of reasons, mostly because these hearts are usually come from generally relatively young, relatively healthy individuals. There's always case reports of, AS. There have been case reports of taking bicuspid heart transplants. I believe there have been a few bicuspid valves that have been done, and those are at higher risk of aortic valve disease. But it's a pretty rare occurrence. Not something I would generally worry about if you were to go forward with a transplant.
I would agree. Okay, Paige, you've been hanging in here for a long time. Do you see patients with myocardial bridging with non-obstructed HCM? So a bridge, so Bipul, could you tell us what a bridge is, and then where would you see it?
So the heart has its own circulation, which is called the coronary arteries. And the coronary arteries, they come off the big tube, the aorta, close to the aortic valve. And then there is a right coronary artery and the left coronary artery, and the left coronary artery divides into two coronary arteries. And in most people, the coronary arteries lie in a layer of a little fat tissue that overlies the heart. But in some people, the coronary artery, rather than staying on the surface of the heart, actually dips into the muscle. And then it could be a short course or a long course, and it's buried in that muscle. So that is called myocardial bridging, because the part of the coronary artery is bridged under the heart muscle. Depending on what you're looking at, there is some data suggesting that patients with hypertrophic cardiomyopathy have higher prevalence of this myocardial bridging. Whether it causes symptoms is very debatable, and it's hard to prove as well. But many surgeons, not all, but some surgeons who do septal myectomy, or if you don't have hypertrophic cardiomyopathy, but you have this bridging and you need bypass surgery, may unroof this artery. In hypertrophic cardiomyopathy, unroofing a coronary artery during septal myectomy, some surgeons will do it, some others. So it's an area of debate.
Okay. So her doctor found the bridge 20 years after the diagnosis of HCM, and she was very happy to hear some content on non-obstructed HCM. So you're welcome. Last but not least here, once we're done with this question from Hugo, we're going to stop recording and we're going to stop Facebook. And if there's any last minute questions, now's your chance to key them, because I'm not sticking around too long because we're running really late tonight. So start typing if you have a private question to ask. I won't ask it until we're ready here. Hugo would like somebody to speak to the relationship between atrial fibrillation and diastolic heart failure in HCM. Are there any specific tips to managing this?
Am I stuck with that one too? Yeah, it's a tough one. So AFib is definitely way more common in really all across the spectrum of heart failure diseases. It doesn't matter whether it's systolic heart failure, diastolic heart failure, whether it's caused by HCM or sarcoid or amyloid. If you label someone as having heart failure, the odds of them having AFib goes up significantly. And one of the reasons is physiologic. Whatever is driving the left ventricle to develop signs and symptoms of heart failure, all of that backfill of pressure that can't get pumped forward ends up in the left atrium. And so your left atrium has a tendency to dilate. And I always go back to just simple thought process. As you stretch the left atrium, you're stretching the electrical system too. So just like in a copper wire in your house, if you pull too hard, you fray some of the wires and you get a short. Same thing happens in the heart. You stretch the left atrium and that wiring gets frayed and you end up in AFib. So it's really, really common, particularly as you get older, it's very common. And as the heart gets sicker, it's very common. My philosophy and really well supported by the literature is early and aggressive treatment of AFib, because the longer you stay in AFib that it's not addressed, the harder and almost impossible it becomes to get out of it. And your left atrium actually contributes to your cardiac output. So left atrium provides about 15 to 20% of your what we call left atrial kick. Your cardiac output is generated from the left atrium contracting and pumping that little bit of extra blood into the left ventricle so that it can get dispersed to your body. And when you're an AFib, you lose that atrial kick. You lose 15 to 20% of your cardiac output. So we take a pretty aggressive approach here. It's unfortunate Dr. Chuprin's not on the call here. He's our go-to HCM AFib guy. And but we all are on the same page as a team. We obviously, if it's an emergency, we'll cardiovert you, get you out of it for the weekend. But we're very aggressive with ablations any and all times possible, even if it's your third, fourth, fifth ablation. Sometimes, if we think there's a successful chance of getting you out of it, at some point there's diminishing returns, and if we don't think we'll be able to achieve that, combining an antiarrhythmic with an ablation, so not just doing the ablation, letting you go home, but starting you on dofetilide or amiodarone or perhaps a couple other agents. Anything and everything we can to try to keep you in sinus rhythm, because once you lose that atrial kick, it's gone forever. It's never coming back. So we try to be aggressive. Lisa made a face when I said 5 ablations. That's extreme. We usually don't go to 5. But we will offer patients 2 to 3 ablations generally. With each added ablation, you can meet increased level of success. But it's really important to be aggressive with it early on. The longer you wait and the less aggressive you are, the harder it becomes to maintain sinus rhythm.
And the mapping techniques that are being utilized,
Right.
the volume of the center you're at. Our typical experience has been 40% success with the first ablation, 40% with the second ablation, 20% with the third, very small after that, sometimes nothing. So it also depends on which center did it, how aggressive they were,
Right.
where they targeted, what type of mapping they used. There's all the technical stuff that you always have to lump onto it, but AFib is horrible. 2 of my family members had very, very significant atrial fibrillation. My dad was cardioverted over 13, 14 times in his life. His left atria was enormous, and the HCM itself didn't bother him, but him in AFib, the poor guy.
Right.
And it was horrible to watch. So I am very sympathetic, and we have many clients who have AFib. It's a nasty process. So I do encourage patients in their HCM process to have a very strong understanding of their left atrial anatomy. What is the measurement? And as that measurement starts to grow, you really need to think about bringing the pressures in the ventricle down to stop that atrial stretch. I'm thinking there may be a role for myosin inhibitors here. There may be a role in the non-obstructed as well as in the obstructed, but we really need to evolve that science, because that could be a game changer for people with HCM earlier, regardless of obstruction. If you can lower the pressures in the left ventricle, you can lower the pressures in the atria and maybe stop that stretch and maybe stop the burden of atrial fibrillation. This is my hope for the community. I send it out to the universe and bring us some science to prove the point. Any comments on my hypothesis?
Another important point is stroke risk in patients with hypertrophic cardiomyopathy. So we don't use the traditional risk factors for risk of stroke in hypertrophic cardiomyopathy. Each patient with hypertrophic cardiomyopathy, if they've had AFib, they are at higher risk of stroke. So anticoagulation is extremely important.
Fantastic. Facebook, thanks for joining us. Good night.